It turns red.
Oh, that button.
The Subcommittee on Health, Employment, Labor and Pensions, and Workforce Protections will come to order. Welcome, everyone. I note that a quorum is present. I note for the subcommittee that Congresswoman Bonamici of Oregon and Congresswoman Shara of Washington are permitted to participate in today's hearing with the understanding that their questions will come only after all members of the Health and Workforce Protections subcommittees on both sides of the aisle who are present have had an opportunity to question the witnesses. The subcommittees are meeting today in a hearing to receive testimony on addressing our nation's maternal and infant health crisis. Pursuant to Committee Rule 7C, opening statements are limited to the chairs and the ranking members. This allows us to hear from our witnesses sooner and provides all members with adequate time to ask questions. I recognize myself now for the purpose of making an opening statement. Today, we are gathered for a bipartisan hearing to discuss our responsibility to address America's maternal and infant health crisis. During this hearing, we will confront the troubling reality that the United States has the worst maternal mortality rate among developed countries. Each year, 700 women die from pregnancy-related complications, and 50,000 women suffer from life-threatening pregnancy-related complications. Even as our peer nations across the world make significant improvements in maternal and infant health, outcomes in the United States are moving in the opposite direction. In fact, the U.S. maternal mortality rate in 2016 was nearly 17 per 100,000 live births, more than double the rate in 1987. This impacts communities across the nation, including my own. In Florida, the situation is even more severe. The maternal mortality rate is 22.3 deaths per 100,000 live births, well above the national average. Miami-Dade County had a maternal mortality rate for Black women of 34.3 in 2018, more than double the national average for all mothers. These numbers are unacceptably high. Improving maternal and infant health requires us to focus not just on the health of mothers during pregnancy, but on their overall health. That means providing consistent, quality, and affordable health insurance to the roughly 11% of reproductive age people, 10.6 million Americans, who went without health insurance in 2017. 14 states still have not expanded Medicaid eligibility, which pays for 43% of births, to cover more low-income people. In those states, women may lose their insurance just 2 months after giving birth. It means supporting the Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, which is proven to help protect the health of both mothers and infants by providing breastfeeding support and helping mothers avoid preterm births. A recent study found that infants born to WIC participants are 33% less likely to die than non-participants. Despite this track record, WIC saw the lowest number of participants in over a decade in 2016. Instead of restricting access to quality health care, Congress must pass legislation to expand access to programs like WIC that have helped mothers navigate healthy pregnancies for decades. Finally, and most importantly, addressing the maternal and infant health crisis means undoing structural racism that affects every facet of American life, from health care to housing to education and transportation. Black mothers are 3 to 4 times more likely to die from pregnancy-related complications than white mothers, regardless of their education and income. Native American mothers are 2 to 3 times more likely to experience maternal mortality than white mothers. Simply put, if we are to stop this crisis, we must all work together and address the complex issues in maternal and infant health. That is why I'm pleased we have an opportunity today, with the help of our witnesses, to discuss how we can make meaningful and immediate steps to improve maternal and infant health for all people. I look forward to today's bipartisan discussions and thank our witnesses again for joining us. I now recognize Health Ranking Member Mr. Wahlberg for an opening statement.
Thank you, Madam Chairwoman. Today we are here to discuss the critical issue of infant and maternal health, and in fact to, I would hope, exalt motherhood and birth itself. While women around the globe are dying less from childbirth, here in the United States the rates have been climbing. Other countries with rising maternal mortality rates: Afghanistan, Lesotho, and Swaziland. For Black women, the statistics are even more troubling. According to the World Health Organization, the maternal mortality rate for Black women in the United States are the same for women in Mexico, Uzbekistan, and this is unacceptable. This issue, a matter of literal life and death for women and babies, demands a serious and thoughtful response. The exact causes of the United States' high maternal and infant mortality rates are unclear and varied, but they can be known. The Health Subcommittee has jurisdiction over employment-related health benefits and the Employee Retirement Income Security Act, otherwise known as ERISA. So as we study the important issue before us today, and before this committee considers the imposition of additional government mandates that could have unintended consequences on employers and employees alike, we should closely examine this problem through separate hearings about the larger issue and propose legislative solutions. As we have learned from experience, one-size-fits-all government requirements more often than not compound the problem. That's why specific policies from this committee and Congress must involve a thorough review of the current problem and a recognition that community, individual, and family engagement are also key components which need to be recognized and addressed. Let's not forget the important role employers are playing in providing health insurance to mothers and babies. Because of our strong economy, more workers have access to high-quality, affordable health insurance at work. The most recent Congressional Budget Office numbers indicate that 159 million Americans are covered by employer-sponsored coverage. In addition, maternity benefits are often the largest type of health care expenditures for employers. Because of this, employers proactively offer a number of programs aimed at increasing quality and lowering costs for employees, and another reason for encouraging economic growth and employment. Many employers offer programs for fertility, prenatal care, neonatal and premature birth medical care, lactation, consulting, and transparency tools to view provider and hospital quality metrics as well. Employers also rely on payment and delivery model reforms to reduce scheduled preterm births, direct high-risk patients to high-quality providers and hospitals, or lower costs by offering bundled payments to providers for childbirth services. Milk delivery services have also gained popularity with employers by offering convenient shipping services for employees who travel for business. While employers, communities, and families all play a pivotal role in decreasing maternal and infant mortality rates, we must also ensure that Congress is taking the necessary steps to guarantee the safety and well-being of women and newborn and unborn infants. We should promote policies in Washington that encourage a strong family, allow families to flourish, and protect life at all stages, from conception to natural death. I know that both sides can agree that maternal and infant health is an issue worthy of attention, and it's my hope that we can hold additional legislative hearings on any proposed solutions, and that any subsequent legislation can be considered in a bipartisan manner. I certainly commit myself to that. Bottom line, bringing a child into the world should be an exciting and joyful time for women and their families, in light of the eternal truth that, quote, children are a gift, the fruit of the womb is a reward. Mothers should feel secure and confident in their new role and not have to fear for their own life or their baby's life. I thank the chairwoman for scheduling today's hearing, and I look forward to hearing from our witnesses. I yield back.
Thank you so much, Mr. Wahlberg. I now recognize Workforce Protection Subcommittee Chair Adams for an opening statement.
Thank you, Madam Chairwoman, and thank you to our witnesses for being here today. As co-chair of the Black Maternal Health Caucus alongside Ms. Underwood, I'm grateful for today's bipartisan opportunity to focus on our role in addressing America's maternal and infant health crisis. This crisis is devastating communities across the country, particularly Black and Native communities that experience far worse outcomes than their white counterparts. However, in some places in the country, such as in my home state of North Carolina, there are strategies in place that have been proven to work in reducing these disparities. It's up to us as lawmakers to make it easier for our caregivers to take what works and expand upon it. Today, our witnesses will help us understand and address the causes behind pregnancy-related mortality and morbidity that hit our communities every day. As Chairwoman Wilson noted, expanding access to affordable health care and nutrition services is an important part of the solution. However, as women increasingly work later into their pregnancies and return to work shortly after the baby is born, we must also ensure that our workplaces support the health of mothers and infants. In this area, federal law falls woefully short. For example, federal law currently does not guarantee all new mothers the right to express breast milk. Workplace breastfeeding supports, such as designated pumping breaks and private space, are particularly critical for both maternal and infant health. Unfortunately, while employers are required to provide pumping breaks and break time for some workers, a gap in the law has caused millions of overtime-exempt employees to fall through the cracks. Further, even covered workers have limited avenues to ensure their employers provide pumping breaks and a private space. I think we can all agree that this is unacceptable. There's no question that our country is facing a maternal and infant health crisis. There's no question that our mothers and infants are suffering preventable tragedies that rarely occur in other developed nations. The only question is whether we will come together and fulfill our responsibility to find solutions and to take action. Again, I want to thank all of the witnesses for joining us today, and Madam Chair, I yield back.
I now recognize Workforce Protection's Ranking Member Walker for an opening statement.
Thank you, Madam Chair. Bringing a child into the world should be an exciting and joyful time for women and their families, not one clouded by fear and by worry. Unfortunately, infant and maternal mortality rates in the United States paint an abysmal picture. From 1990 to 2015, the U.S. maternal mortality rate increased by 34%. To put that number into proper perspective, the global rate for maternal mortality decreased by 44% over that same time period. As for United States infant mortality rates, they are declining, but remain 71% higher than the comparable country average. Considering that the cause of these worsening and troublesome trends are unclear, we must be cautious of implementing government mandates on employers that could end up, potentially, doing more harm than good. With that said, though, public policy has an important role to play in this issue, which is why there are protections under federal law that safeguard mothers and their newborn babies' health. For example, the Fair Labor Standards Act, the FLSA, requires employers to provide reasonable workplace accommodations and break time for nursing mothers for 1 year after their child's birth. Women with children are the fastest growing segment of the workforce. According to the Department of Health and Human Services, 6 in every 10 new mothers are in the workforce. So, the types of accommodations included in the FLSA help our nation's workers and job creators succeed. We agree that maternal and infant mortality trends are an important concern which deserves our attention. In the past, Congress has been able to come together in a bipartisan manner to tackle serious policy challenges. For example, last year, Congress passed H.R. 6, the Support Patients and Communities Act, bipartisan legislation to address the opioids crisis, including mothers and infants affected by this terrible epidemic. Our hope is that we can continue this bipartisan work as we discuss solutions to address maternal and infant health here today. In closing, hundreds of maternal deaths occur every single year. These statistics are heartbreaking. As a nation with some of the most advanced obstetrics and emergency care, we can and we should do better. But it is important that we legislate with a reasoned approach backed by a careful examination of the issue, which is why this hearing is a good starting point. Again, thank you, Madam Chairwoman, for scheduling today's hearing. I look forward to a thoughtful discussion and hearing from all of our witnesses on how we can improve maternal and infant health conditions. Yield back.
Thank you. Without objection, all other members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m. on February 10th, 2020. I will now introduce our witnesses. Stacy Stewart is the president and CEO of the March of Dimes. In this role, Stewart heads the organization leading the fight for the health of all moms and babies. Nakia Sankofa is the executive director of the United States Breastfeeding Committee, an independent nonprofit coalition of more than 100 influential professional, educational, and governmental organizations that share a common mission to drive collaborative efforts for policy and practices that create a landscape of breastfeeding support across the United States. Dr. Gioia Perry is the founder and president of the National Birth Equity Collaborative and a board member of the Black Mamas Matter Alliance. She is a thought leader around racism as a root cause of health inequities. Welcome to each of you powerful Black women. We appreciate all of you for being here today, and we look forward to your testimony. Let me remind the witnesses that we have read your written statements, and they will appear in full in the hearing record. Pursuant to Committee Rule 7D and committee practice, each of you is asked to limit your oral presentation to a 5-minute summary of your written statement. Let me also remind the witnesses that pursuant to Title 18 of the U.S. Code Section 1001, it is illegal to knowingly and willfully falsify any statement, representation, writing, document, or material fact presented to Congress, or otherwise conceal or cover up a material fact. Before you begin your testimony, please remember to press the button on the microphone in front of you so that it will turn on and the members can hear you. As you begin to speak, the light in front of you will turn green. After 4 minutes, the light will turn yellow to signal that you have 1 minute remaining. When the light turns red, your 5 minutes have expired, and we ask that you please wrap it up. We will let the entire panel make their presentations before we move to member questions. When answering a question, please remember to once again turn your microphone on. I will now recognize Ms. Stacy Stewart. Welcome, Ms. Stewart.
Thank you, and good morning, Chairwoman Wilson and Chairwoman Adams, also Ranking Member Wahlberg and Ranking Member Byrne, and members of the subcommittees. It is a pleasure for me to be here today, and thank you for inviting me to testify. My name is Stacy Stewart. I'm President and CEO of the March of Dimes. Every day at March of Dimes, we lead the fight for the health of all moms and all babies. We began that fight more than 80 years ago as an organization dedicated to eradicating polio in the United States, a goal that we achieved. We continue that fight today as we work to address some of the biggest threats to moms and babies, such as premature birth and maternal mortality, through research, through education, programs, and advocacy. March of Dimes' mission is more important than ever before, as our nation, as many of you all have mentioned, is in the midst of a maternal and infant health crisis. 2 babies die every hour in the United States, and 1 woman dies every 12 hours as a result of complications from pregnancy and childbirth. The most recent March of Dimes report card shows that the nation's preterm birth rate rose for the 4th year in a row in 2018, and it revealed unacceptable disparities in outcomes for babies born in certain communities. Infants of color and those born in the southeastern United States are much more likely to be born too soon. In fact, the preterm birth rate among Black women is 49% higher than the rate among all other women. The state of maternal health mirrors that of infants born too soon. Outcomes are getting worse, and those worsening outcomes are driven by disparities. Each year, approximately 700 women die from pregnancy complications, and for every maternal death, another 70 women suffer life-threatening health challenges. That's 50,000 women every year. These startling statistics make the U.S. one of the most dangerous developed places in the developed world in which to give birth. The threat is especially acute for women of color. Black mothers of all ages are 3 times more likely to die from pregnancy-related causes and complications than their white peers. For Black and American Indian and Alaska Native women over the age of 30, rates of maternal death are 4 to 5 times higher. We need your help to address this crisis by focusing on policies that will improve both maternal and infant health. March of Dimes was pleased by the passage of the Preventing Maternal Deaths Act and the Preemie Reauthorization Act in late 2018. Both of these bills continue vital programs to collect enhanced data on the causes of maternal mortality and premature birth. Fortunately, we don't have to wait for new data to take additional action. We know that the causes of this crisis are diverse. They can be traced to issues in our healthcare system, including quality of care and implicit bias. They stem from factors in our homes, in our workplaces, in our communities. There are additional steps you can take today to address this crisis. A full description of those steps can be found in my written testimony, but I will address policies most relevant to the subcommittee's jurisdictions now. First, Congress should take all necessary steps to ensure that women have access to comprehensive and affordable health care before, during, and after pregnancy, and guaranteeing her newborn has the same from birth. The Patient Protection and Affordable Care Act codified a number of vital provisions, including protecting individuals with pre-existing conditions, guaranteeing coverage for maternity care, and ending annual and lifetime caps on coverage. Lawmakers must protect and build upon these protections. The March of Dimes supports creating a new special enrollment period for pregnancy, as outlined in the Healthy Mom Act, to ensure all pregnant women have access to prenatal care. We also support efforts to protect families from surprise bills by simplifying the process for enrolling newborns in a family's health plan. Congress can guarantee women and infants have access to both preventive care and treatment by strengthening the ACA's requirements that health plans cover preventive services for women and infants without cost sharing. Further, lawmakers should require health plans to cover a minimum number of free healthcare provider visits each year, as outlined in the Primary and Behavioral Health Care Access Act. While health insurance and healthcare services are essential to healthy moms and babies, we cannot address this public health crisis by focusing exclusively on doctors, offices, and hospitals. We have to address the barriers in our communities as well. We also applaud efforts to improve the WIC program. We strongly support reforms to ensure that every mom, no matter where she works, can continue to breastfeed if she chooses. I look forward to expounding upon some of the proposals that we're talking about today, and thank you for having me.
Thank you, Ms. Stewart. We will now recognize Ms. Nakia Sankofa. Welcome.
Good morning, Chairwoman Wilson and Chairwoman Adams and Ranking Members Wahlberg and Walker. It's on? You got it. You go ahead. Okay. Thank you for this opportunity to participate in today's hearing to discuss America's maternal and infant health crisis. It's an honor to share the insights I've gained from 2 decades of public health work at the community and national levels. I am the Executive Director of the United States Breastfeeding Committee, an independent nonprofit coalition of more than 100 national, tribal, regional, state, and community organizations working together to drive policies and practices that create a landscape of breastfeeding support throughout the country. Breastfeeding is a proven primary prevention strategy, building a foundation for lifelong health and wellness. Compared with formula-fed children, breastfed infants have a reduced risk of illness, infection, and infant death. Women who breastfeed their children have a reduced long-term risk of diabetes, cardiovascular disease, and certain cancers. The evidence for the value of breastfeeding to children and women's health is scientific, robust, and continuously being reaffirmed by new research. Leading health organizations recommend exclusive breastfeeding for about 6 months, followed by continued breastfeeding as complementary foods are introduced for at least the first year of life. You might think that infant feeding decisions are a personal family matter, but we are all shaped by our circumstances. Lack of education in the prenatal period, maternity care practices that do not prioritize breastfeeding, returning home after birth, unsure of where to go for support, and having lack of access to counseling and supplies, such as breast pumps, can compromise the early establishment of breastfeeding. And lack of support in the community and employment settings can stand in the way of continued breastfeeding. Recent data show that 84% of infants were ever breastfed, meaning that they initiated breastfeeding, indicating that most mothers in the United States want to breastfeed and start out doing so, but only a quarter are still breastfeeding exclusively at 6 months. No wonder 60% of mothers report that they did not breastfeed for as long as they intended. Some of these barriers to breastfeeding exist outside of the mother's sphere of power or control, and they disproportionately impact young women, those with low income, and women of color. This is reflected in significantly lower breastfeeding rates across all tracked indicators for these populations. The key to supporting families and alleviating breastfeeding disparities is investing in upstream policy, system, and environmental change solutions that deconstruct barriers and build environments where healthy choices like sustained breastfeeding can be the easy default option for most families. Some well-known breastfeeding policy system and environmental change solutions include the Baby Friendly Hospital Initiative, WIC's Breastfeeding Peer Counselor Program, and the 2010 Break Time for Nursing Mothers Law, which was unanimously passed out of a bipartisan committee in recognition of the role that breastfeeding plays in infant and maternal health. Even with these systemic solutions in place, we know more must be done. A simple and common sense policy solution to addressing ongoing workplace barriers is within reach of this committee. The Providing Urgent Maternal Protections for Nursing Mothers Act, the PUMP Act, was introduced with a bipartisan support for breastfeeding employees, and it helps breastfeeding employees while clarifying implementation processes for employers across the nation. Nearly 1 in 4 women of childbearing age, that's 9 million employees, are excluded from coverage under the current break time law. And as such, they have no clear right to break time and a private space to pump breast milk. Although state legislation covers more than half of these employees, creating federal laws ensures that employers from all sectors are considered and employees from all communities are supported under a national law that recognizes the importance of breast milk in human and population health. Without protections, breastfeeding employees face serious health consequences, including risk of painful illness and infection, diminished milk supply, or inability to continue breastfeeding. According to a recent report from the University of California's Center for Work-Life Law, the consequences of this coverage gap also include harassment at work, reduced wages, and job loss, putting some new mothers in the position of risking their family's economic security by attempting to continue breastfeeding and working. The Pump for Nursing Mothers Act, which strengthened the 2010 break time law by closing the coverage gap for women who are not currently covered, providing employers clarity on when pumping time must be paid and when it may be unpaid, and providing remedies for nursing mothers. We know that the vast majority of people become parents during their lifetime, and their needs and the needs of their infants are neither surprising nor difficult to meet if we plan appropriately. Thank you for this opportunity.
Thank you, Ms. Sankofa. We now recognize Dr. Gioia Perry. Welcome.
Thank you so much. Thank you, Chairwoman Wilson, Chairwoman Adams, Ranking Members Wahlberg and Byrne, as well as members of the House Committee on Education and Labor for allowing me, Dr. Gioia Perry, to provide testimony for this Expecting More, Addressing America's Maternal and Infant Health Crisis hearing representing the National Birth Equity Collaborative and the Black Mamas Matter Alliance. We can support improvements for all workers of reproductive age to grow their families with the appropriate wages, dignity, and protections they deserve. Women are integral to every industry in the U.S. Can they trust this body to support them through their pregnancy and return to the workforce? We can begin by shoring up the existing state investments for new mothers that are based upon evidence, like diversifying our workforce, scaling and deepening the ACOG Alliance for Innovation on Maternal Health, and building a community for respectful care, increasing our investment in the CDC-supported perinatal quality collaboratives, mandating implicit bias and anti-racism trainings, and uplifting the leadership influence of the National Institutes of Health Office of Research on Women's Health on federal divisions. We can solidify these investments by heeding the recommendations of entities like us at the Black Mamas Matter Alliance. As has been mentioned, the CDC defines pregnancy-related death as the death of a woman while pregnant or within 1 year or the end of pregnancy, regardless of outcome, duration, or site of the pregnancy, from any cause related to or aggravated by pregnancy and its management. Based on that definition, the CDC found in their surveillance 2,726 women died in the United States between 2011 and 2014. And of those, 1,010, or 38%, were Black. Based on that data and estimates of maternal mortality data from the CDC, a modest estimate of loss of preventable causes is about 1,500 to 1,000 to 1,500 Black mothers in the last decade. That's a caravan of coach buses each year. This is unacceptable. Furthermore, over 60% of these deaths were preventable. As a Black woman from the Deep South who is an obstetrician and a mother, my strong desire to end this inequity is amplified every time I look into the faces of my daughter and my patients. The legacy of a hierarchy of human value based upon the color of our skin continues to cause differences in health outcomes, including maternal mortality. Racism is the risk factor, not my black skin. There is no black gene. Race is a social and political construct. Maternal mortality extends beyond the period of pregnancy or birth. 9 months of prenatal care cannot counter underlying social determinants of health inequities in housing, political participation, transportation. Currently, we do not have access to maternity care that is culturally congruent. Lack of workforce diversity and provider shortages are a direct consequence of policies created in halls like this that date back to the 1921 Shepherd-Towner Act, among others. I am the founder of the National Birth Equity Collaborative and on the founding board of the Black Mamas Matter Alliance. The National Birth Equity Collaborative creates solutions that optimize Black maternal and infant health through training, policy and advocacy, research, and community-centered collaboration. When working with large hospital systems, as we currently do, health departments, and large legacy organizations to build a culture of reproductive justice, we have learned that federal policy and investment is critical. As Black birthing people, we have been devalued for generations, and that devaluation shows up in your policy choices that you picked today. The Black Mamas Matter Alliance serves as a national voice and coordinating entity for stakeholders advancing maternal health, rights, and justice, and intentionally centers Black women's leadership. BMMA has a network of organizations with reach and relationships and capacity that you could support for a intergenerational movement. Ultimately, what Black women in the United States need is accountability. We need to know that our lives are valued. This accountability may be complicated, but government still has an obligation to act. Racism, classism, and gender oppression are killing us, from rural to urban America. This is not about intentions. Lack of action is unintentionally killing us, and it's a human rights imperative. This hearing calls that calls for us to expect more is an opportunity for esteemed members of this Education and Labor Committee to look deeply at all the ways policies around our social determinants of health are causing maternal morbidity and mortality. We must be willing to continue to name this problem directly. Yes, Black mamas matter. Thank you.
Thank you, Dr. Perry, Correa Perry. Under Committee Rule 8A, we will now question witnesses under the 5-minute rule. I will now yield myself 5 minutes. Dr. Correa Perry, in your testimony, you discussed the history of the Shepherd-Towner Act of 1921 and the impact it had on midwifery and Black midwifery in particular. How many Black midwives are in practice, and what policies do you think Congress could pursue to increase the number of Black midwives?
Well, we currently know that less than 5% of midwives in practice are Black. And we also know that there's a shortage of midwifery in general in this country. When that act was enacted, we were still operating in a belief that people of color and Black people were not fully capable of providing the care that everyone needs. And so we did things like that were harmful and didn't value the women who had been birthing America for generations. So there's an opportunity for us to say, well, what is it that people and patients want? When we interview women, they really want less intervention. They want a midwife. They want someone who looks like them, who understands them. So an opportunity through Congress is to increase the workforce development, have nursing programs at HBCUs like my own hometown of Grambling, to ensure that we have access to midwifery programs, because that's a direct pipeline. There are nursing schools at a lot of the HBCUs. They do not have access to midwifery programs as well.
Thank you. In your testimony, you discussed some of the history of racism within the field of obstetrics and gynecology. Today, we know that when Black women seek medical treatment, they receive a lower quality of care than their white counterparts. Can you say more about the role of Dr. J. Marion Sims in this history of OBGYN?
Yes, thank you so much. So as you may know, Dr. J. Marion Sims traveled across the United States with 3 Black women who were enslaved. Their names were Lucy, Betsy, and Anarcha. I like to uplift their names because they're human beings who existed, who we don't even honor, and they don't have statues. We have statues and honors for J. Marion Sims. We name, if you're an OBGYN and you reach for a retractor, you're asking for a Sims retractor. That name comes from a man who traveled around the country doing experiments on women without any anesthesia. And then he wrote, based upon the fact that these Black women could handle these surgeries without anesthesia, that we clearly did not feel pain the same way that white women did. And that belief still pervades today. There are studies that show from prestigious universities in the United States that medical students still believe that Black people do not feel pain the same way, as if melanin has something to do with your pain receptors. So it's important for us to really think about all the ways that racism is embedded in how we created obstetrics and gynecology, how we decimated midwifery, and how we still provide care today, and how we do not acknowledge those truths. We're not taught even about J. Marion Sims when you're training in medical school or residency, so you don't even have an understanding of the retractor that you're asking for and how it was used and created on the bodies of people who were not valued.
Okay, thank you. About 1 in 33 children in the United States is born with a congenital abnormality. Some of these conditions, such as a cleft palate, can have serious impact on a child's ability to breathe and to speak. Ms. Stewart, does March of Dimes support legislation such as ensuring Lasting Smiles Act that would close this gap in coverage for these children?
Thank you, Chairwoman. Yes, the Ensuring Lasting Smiles Act is federal legislation that would do some very important things. First of all, it would ensure that all private, group, and individual health plans cover medically necessary services, including needed dental procedures as a result of congenital anomalies. And as you mentioned, about 4% of children in the U.S. are born with these kinds of anomalies. Or birth defects, and of course the March of Dimes in our history has been very dedicated to addressing the issues of birth defects among children. But the issue is that while most private health plans do provide coverage for surgical treatment of many of these anomalies, and there are many states that actually require insurers to provide coverage for health services related to some of these birth defects, we still hear that there are too many health plans that often deny claims and appeals for oral or dental-related procedures like orthodontia or dental implants and other procedures. And what this means for these families is that they are often left to have to figure out how to pay for these services on their own. And some of those expenses can be extraordinary and often devastating financially to many of these families. So what we support the Ensuring Lasting Smiles Act along with over 30 other organizations because we think that when babies are born, due to no fault of their own or their families, with these kinds of birth defects, they deserve and need the treatment, often these dental surgeries, to make sure that not only can they really thrive as kids, but they can actually function as normal human beings, because some of these kinds of birth defects affect their ability to breathe, their ability to eat. They're more than just cosmetic surgeries. They are actually medically necessary and medically indicated surgeries. So we are in strong support of the Ensuring Lasting Smiles Act because we believe that it would provide the support that is needed to so many of these families. Some of these families are even here today, like the Abbott family from Wisconsin. I just got a chance to meet, and families that have been really impacted by some of these issues. And without some of the support from the Ensuring Lasting Smiles Act, we would leave too many families too vulnerable.
Thank you.
And without the care that they need.
Thank you very much. I ask unanimous consent to enter into the record letters of support for this legislation. I now recognize Member Wahlberg, my ranking member, for his round of questions.
Thank you, Madam Chairwoman, and thanks to the panel for being here today and taking the effort to join us this morning. Ms. Stewart, last Congress, I was proud to serve as a member of the Energy and Commerce Committee as we passed a bipartisan bill, H.R. 1318, the Preventing Maternal Deaths Act, which reauthorized funding for the Centers for Disease Control and Prevention programs that support state and local maternal mortality surveillance and prevention programs. Added additional funding for state governments to establish maternal mortality review commissions. H.R. 1318 was signed into law by President Trump in December 2018. These state commissions work to collect, to track, analyze, and report data on maternal and infant outcomes. In states that have established these commissions, how has the increased availability of data impacted maternal safety and quality improvement initiatives?
Thank you. Well, one of the things that's really important as we address the maternal and infant health crisis is being able to collect good data, good reliable data across the country. And thank you for your support for the Preventing Maternal Deaths Act, because it did provide the impetus for every state to be able to establish what we call a Maternal Mortality Review Committee, We now have every state, with the exception of 3, that have established these MMRCs. And what they're doing is actually collecting the data, the underlying data that's really important to understand the cause of death, why a mother may have died as a result, and tie it back to, obviously, the fact that she may have just had a baby or any of the causes due to pregnancy or childbirth. These state-based committees are full of experts who really analyze this data and then help design recommendations or interventions to prevent further deaths from happening. So before this, we didn't have this kind of data collection effort. Now that we do, we're able to look more deeply at the underlying causes of maternal mortality and morbidity and design at a federal level or at a state level the kinds of interventions that will hopefully prevent these kinds of deaths from happening in the future. We would not be able to do this work and accelerate our interventions and our successes with this crisis if we didn't have more robust data collection.
It'll certainly take some time for that to work in, but we are seeing benefits already.
We're starting to see benefits. We still have 3 states that need to establish the MMRCs, and then we need to start collecting the data and reporting it up.
What are those states?
South Dakota, North Dakota, and Wyoming, as I understand.
Okay. Dr. Correa, high-risk pregnancies can pose significant challenges to all women and to health providers. I'm a grandfather, and when I'm asked how many grandkids I have, I say 1 in heaven and 5 on the ground. My first 2 were twin boys, born at 24 weeks, 1 pound, 12 ounces, 12 inches long. John Timothy is in heaven waiting, but thanks to the wonderful care that they received in Northwestern University Hospital, north side of Chicago. Mike is now 13 and almost 6 feet tall, healthy, and going strong. But my daughter-in-law also was part of that process, and thank God she was given great care and pulled through. So it's an important issue that we're talking about today. Some hospitals have successfully implemented standard protocols to address common high-risk scenarios. How, in looking at labor and delivery issues, hemorrhaging, high blood pressure, et cetera, how can these protocols help increase quality and decrease maternal mortality rates?
I had a 1-pounder myself. He's now 23 years old. He was supposed to come with me this morning, but he played video games too late last night, so he's not here with me. So I appreciate that.
So he's
very
normal.
much. Exactly. So I'm making him watch it on YouTube. No, so it's important for us, the way that those tools work is we can have standards for hospitals. So for example, the Joint Commission just passed, who accredits hospitals, asked the hospitals, they have about a year to get it together to report on hemorrhage and how they're using the bundles. And so we've seen improvements. In fact, the state of California saw a large decrease in the number of deaths after really implementing the use of those hemorrhage bundles and hypertension. And what they found, though, is that there still was bias around who was implementing the bundles. So now we're going back to say, how can we do this in a more equitable way? And how can we do things like work on our implicit biases? But it's important to have those tools so that you have a standard of how you're supposed to take care of patients.
Okay, appreciate that. In a very limited time here, Ms. Stewart, we talked about the United States and its problem. As U.S. maternal mortality rates continue to increase, are other countries experiencing similar increases, and are we learning something from that as well?
Well, we're sort of unique in that we're one of the few, if any, of the largest industrialized countries in the world with increasing maternal mortality rates. I think it was mentioned earlier that we kind of stand alone in that respect. I do think there are other things that we learn from other countries where the rates have been declining, and you see a range of other supportive policies to make sure that women are provided the support that they need. In the UK, for example, there are lots of supports that women are given through midwifery care and through other kinds of home visiting programs that actually are providing a lot of support to women during pregnancy and even postpartum. Our country lacks in terms of the ability to expand these kinds of policies to many women, and that leaves many women falling through the cracks. We also know a couple things. One is that we will not solve this issue just by looking at the 9 months of pregnancy. We have to look at women before they're pregnant, during pregnancy, and after pregnancy. We also have to make sure that we look at health care and health and wellness for women as not just something that happens in the doctor's office, because so many of the issues that impact a woman and her health and the baby's health have to do so much with their environment and what we call the social determinants of health, how they live their day-to-day lives. And until we get a full handle on policies that address the totality of how women live in this country, we won't be able to address this issue in the way we need.
Thank you. I yield back.
Thank you. Thank you, Chairman, Ranking Member Wahlberg. I remind my colleagues that pursuant to committee practice, materials for submission for the hearing record must be submitted to the committee clerk within 14 days following the last day of the hearing, preferably in Microsoft. And now we will hear from our members. Dr. Adams, who has been on the forefront of this issue here in Congress, along with Nurse Underwood. I commend them. Now, Dr. Adams.
Thank you, Madam Chair. Dr. Greer-Perry, thank you for highlighting the importance of training providers as a strategy to reduce the racial disparities that we're seeing in maternal and infant health outcomes, and that's why I introduced the Maternal Care Act, which would create implicit bias training grants. In your experience working with physicians and other healthcare providers, how common is implicit bias training, and what kind of gaps do you see in the training of healthcare providers?
So right now, it keeps me very busy doing implicit bias training. We just did one in Kaiser in Atlanta. We trained their entire maternal and child health division, so that's everybody from the people who answer the phone to the actual high-risk OBGYNs. So there is an opportunity we have right now to really build up on these trainings. My organization is one of several that do these trainings, and I know that the March of Dimes has created some work around that as well. And the importance is that we need to understand our own biases in healthcare and how we were taught those things, and biases are not, they're coded in us. We can change it. We don't have to believe that Black people are broken. We don't have to believe that women can't do things. Those are things that we've been taught, and so they're a part of our implicit biases now, but we can change that.
Thank you. My home state of North Carolina has a program called Pregnancy Care Management. It provides needs assessments, coordination of care, and other supports for eligible women with at-risk pregnancies. The program's been cited as a factor in and having the Black maternal death rate in North Carolina. Why is coordination of care and supportive services particularly effective for Black mothers, and what can Congress do to support these types of programs?
I have the honor of working with Dr. Menard and others at UNC around that work, the pregnancy medical home work, and this idea that you can have coordination, because as was mentioned by Ms. Stewart, we're losing people in the gaps. They don't have access to the coordination around breastfeeding, or if they need transportation or housing. So this coordinated care model, which was, I think, spun out through Medicaid, allows for you to then also have coordination with other services in North Carolina, and they've seen a decrease in their Black maternal health mortality. They've also saw the gap close in the disparity in North Carolina. So you should be really proud of your home state for putting that forward.
Well, I am, you
Yeah.
know, some things. So do you agree that WIC has an opportunity to play a greater role in this conversation?
I love our WIC partners. We did a training of implicit bias at the WIC conference last year as well. And so because they touch more moms than most anybody, I mean, people go to WIC when they don't go to their pediatrician, when they definitely don't go to their postpartum visit to see us. And so WIC is an important partner. They already have boots on the ground and they know the mothers.
Thank you. Ms. Sankofa, recently the Department of Labor finalized regulations narrowing its interpretation of joint employment status under the Fair Labor Standards Act, which contains the nursing mother's protections that you discussed. Although the rule does not have the force and effect of law, it tells us how the department will be enforcing joint employment standards for determining if an employer must comply with these requirements. What's the impact of this, and especially where the nursing mother has limited ability to take legal action against the employer? Need to turn your, okay.
All right. I think that's an excellent question, and I appreciate it because I really think that it makes it more difficult for the lactating mother to really enforce their right to have a clean and private place to pump and store their milk while they're at work. As I said at the end of my oral testimony, when employees don't have a clean and adequate safe space, private space, in order to pump their milk, they have to make these difficult trade-offs. And this trade-off is, do you want to stay employed and have economic viability for your family, or do you want to provide the nutritional biological standard for your infant? And I think it's important. We often say that breast is best. While it's true, breast is the nutritional standard. It's what everybody is supposed to have. It's how people are fed, and everything else is actually something that is inferior to breast milk.
Right, okay, so protections that entitle nursing workers to break time and private space to express milk are only available to those who are eligible for overtime pay. So who are we leaving out by only protecting who's eligible for overtime pay? And is there a policy reason why these women should not have the right to break time in a private space to express milk?
We're leaving out, as I said, up to 9 million workers in the United States, and those are typically salaried employees. That includes people who you know, like if you all have children, you have teachers in your life. So it includes teachers, it includes nurses, it includes software engineers, it includes many of the people who you encounter every day. And I don't know that there's actually a policy reason that these families are not covered by the break time for nursing mothers law. I think that placement in statute made that that gap present, and I think that the PUMP Act gives us the opportunity to kind of right size. We have 10 years of recognized defects within the system to be able to really see where we can take the next step to kind of close that gap.
Great, thank you very much, Madam Chair, I yield back. Thank you for your responses.
Thank you, Dr. Adams. Mr. Walker?
Yes. Thank you, Madam Chair. As I listen today, I appreciate the passion of all the witnesses here today. It makes me think of my wife as a family nurse practitioner, and her boss, Dr. Lisa David, is the chair there at Wake Forest Baptist Medical Center, and they work with infants with and children with cleft palates and do great work, so quick shout out to them and their work. Ms. Stewart, you mentioned the increase in the nation's preterm birth rate to 10%. And I'm sad to say, maybe this picks up with Dr. Adams there, our home state of North Carolina even has a higher rate, a 10.4%, I believe a D rating. In the March of Dimes report card, I believe is where that was listed. What would you say attributed to the shift in the preterm birth rate after a decade of decline?
So unfortunately, we don't know all the answers of why the preterm birth rate has increased. What we know is that, in general, health outcomes for moms and babies have generally declined in this country over the past many years. And there are a various number of reasons for it. First of all, I'll just let you know that March of Dimes has 6 prematurity research centers, 5 in this country, 1 in the UK, all working together to try to look at some of the underlying causes, biological reasons why some of this is happening. But we also know that the impact of the way women and families, women especially, live in this country could also have a serious impact. So the degree of stress on women, especially before pregnancy and after, during pregnancy and even after. We also know that the lack of access to care. We have too many women living in places where, even if they have coverage, they may not have care. And there's 2 different things. So we have, even in a state like North Carolina, places, counties that are considered maternal care deserts, where women are not able to access the kind of prenatal care that they need in order to have a successful pregnancy. So there are a variety of reasons for it.
You and certainly my wife would know more than I, but I believe preterm or premature birth is defined as before 37 weeks. Is that correct? Yes. It is the #1 cause of infant death in the United States, with an average of 275 babies being born preterm per week. I know it is in North Carolina. What challenges or complications can infants face who are born preterm, and what challenges do their mothers face as well?
Well, either I can talk about it or Dr. Gioia Perry can, because she has personal experience with it. But we work on this issue as a primary issue for the March Dimes, as I mentioned. 380,000 babies born every year prematurely, again, before 37 weeks of gestation. What we know is that a lot of those preterm births are happening in the period between 34 and 36 weeks, so very late preterm. But some of the most devastating effects happen for a baby like Dr. Correa Perry's baby, born at a very early preterm stage, so at 21 weeks or 23 weeks of gestation. And for those babies, the effects can be devastating. Babies can have developmental delays, cognitive delays, physical disabilities, and a whole range of lifelong health complications that are very expensive to address. One of the things that the March Dimes did is we updated a study on the cost of preterm birth. About over a decade ago, we looked at it at a cost of $26 billion in this country. It's now well over $30 billion. So it has a significant cost on the country from a productivity standpoint, as well as families and those children individually.
Thank you. Certainly, I'm someone that believes that life is precious, whatever term that it might be in. I know that's not our discussion today, but any kind of biases before or after something is important to me. And I know, Dr. Correa, that's kind of your kind of specialty area, if it is, and someone who tries to advocate for all people, I would be concerned about that. So you're telling me that you see biases in there. I'm going to take that at face value, but I also want to ask you, on those biases, do you believe they're intended? Is it out of ignorance? Is it out of unintentional? Can you break that? I've got a minute left. I'm going to skip my final question because I want to hear from you on that as well, because that's important to me. Thank you.
They're definitely not intended. They're definitely things that we all kind of grew up believing. I was taught in medical school by my professors that there were three races: Mongoloid, Caucasoid, and Negroid. That was what I was taught. So I believed that the reason that I had a baby preterm is because I was black, because there was something innately. So that's a bias that we've been teaching that we have to undo, that we have to retrain. My grandmother would say we have to unlearn us, right? We've learned some things that are incorrect. And so it's an opportunity for us to really, we're all the same. There's no difference between you and I. Our biology is the same. And so how do we then think about what are we doing as a country to ensure that we have both good outcomes? That's it.
Thank you, Dr. Correa. Appreciate your passion in that area. With that, I yield back to Madam Chair.
Thank you so much. And now, Mr. Courtney from Connecticut.
Thank you, Madam Chairwoman, and to both chairs and ranking members for holding this hearing. This really, the topic here today should shock the conscience of every American. And what I want to just thank all the witnesses is just that, you've put forth some really, manageable, doable solutions that, again, based on your testimony, I think should encourage us all that we actually have the tools to address this. So again, thank you all for being here today. And also that, these two subcommittees, I think, really, also are positioned to move forward on these issues. Ms. Stewart, you mentioned, and I think Dr. Perry also in your testimony alluded to the fact that the ACA, when it passed, obviously moved the ball forward in terms of maternity care, Medicaid coverage, and also the essential health benefits. But I do think, as Ms. Stewart's testimony indicated, I think it would surprise people to know that the age 26 coverage, which is hands down probably one of the most popular, if not the most popular provision of the law, does not extend to dependent adult children in terms of maternity benefits. The numbers we have is that it's about 4.2 million women ages 19 to 25 that are covered under their parents' health insurance plans, again, have that gap. And Mercer, which is pretty credible institution or think tank study, found that approximately 70% of employers don't cover maternity care for dependents. So again, this is the subcommittee that actually wrote the age 26 provision, because we have ERISA jurisdiction. Again, I wonder if, Mrs. Stewart, you could just sort of talk a little bit about how that's maybe contributing to this issue, that gap.
No, I really appreciate it. And I think you're right in that it is certainly one of the most popular provisions in the ACA that health plans offer dependent coverage for children up to the age of 26. And the inclusion of essential health benefits as a part of ACA has also been a huge benefit to pregnant women for maternity coverage. What we know, though, is that the essential health benefits only apply in the individual and small group market. So these health plans for these large employers who are not required to provide coverage for maternity care for dependents leaves this large gap and this large loophole, about 4 million young women who are covered as dependents but don't have access to this kind of coverage. So we think that it's very important to deal with this loophole that potentially puts a lot of women at risk. It subjects them potentially to a lot of out-of-pocket costs if they become pregnant. And certainly this gap in coverage is actually threatening their own health and potentially the health of their baby if they're not able to receive the proper prenatal coverage and the kind of care that they may need. So addressing this loophole will be very important. And it's, again, millions of women that are left in this gap.
Dr. Perry, I don't know if you'd like to comment as well.
As a person who has a 26-year-old daughter, I was super depressed when she had to get off my insurance. So I appreciate that exists and that it's popular. And you think about who gets pregnant. It's 21 to 26-year-olds, and we're leaving off millions by not having this loophole addressed. So it's important for us to recognize if mortality is something we care about, and morbidity and parenting and mothering, then we would not leave a space where people don't have access to care.
Thank you. I have a 25-year-old, so we're holding on our fingernails. Again, Ms. Wilson, I just want to again thank you for bringing up the issue of the Ensuring Lasting Smiles Act and the impact of that sort of fragile coverage for congenital birth defects. I have a letter which I'd asked to be admitted to the record from Caleb Andrew Locke, who's a 10-year-old just passionate advocate who represents Rhode Island and Connecticut, and describes his own situation, which, as he points out, if it was caused by a car accident, it would be covered. But the fact that it's a congenital defect runs into this obstacle, which is just completely unacceptable. So again, thank you for addressing that issue, and hopefully that bill will move forward because of the spotlight you're putting on it here today. And with that, I yield back.
So ordered. Dr. Bro, you know all about this.
Thank you, Madam Chair. And Ms. Stewart, this has nothing to do with this hearing, but we're working on your pension issue at the March of Dimes, okay?
It only
And I
helps
wanna
us deal with our
congratulate-
other issues, too. Thank you
I
so
want to
much.
congratulate this entire committee. Every one of you finished in exactly 5 minutes, so congratulations. A few things I want to go over very quickly, and Ms. Sankofa, I want to get this on the record of thanking you for advocating breastfeeding. And I think that is a huge thing that you've done, and also to encourage women out there that may be watching this to use the WIC program. My background, I'm an obstetrician, and I've got a little head start on you, Dr. Perry. I've delivered almost 5,000 babies. And one of the things I noticed in my practice, a couple things that have not been mentioned at all, is obesity and drug addiction. And in our state of Tennessee, in 1998, we had 50 opioid-addicted babies in the entire state of Tennessee. It would have been a rarity to ever see it in our. Now we have a NICU, of which the Surgeon General will be there this Thursday visiting our children's hospital, specifically for opioid-addicted babies. And I know absolutely it's depressing to me to see a mortality rate, maternal mortality rate in the late 70s being lower than it is today with all the enormous amount of resources and money we've spent. And would you, Dr. Perry, go, I think it's very important, the definition of maternal mortality, and is it described that way, defined that way in other countries?
I read it, and I would have to, I don't want to mess up the real definition, so I can read it again. But how we define it is a global definition, so that up to 42 days, it is a standard, and whatever, no matter the site or within 42 days of delivery. What we also are starting to do in the United States, though, is recognize women are dying up to a year later. So although the international standard is 42 days, we really don't have, we know that people die from opioid and substance abuse 3 months later, right? And it's still tied to the pregnancy. So we're now tracking deaths up to a year and really pushing the international community to start thinking about doing the same thing.
Just to give you an example, in our state this year, we're trying to take our Medicaid-covered patients whose coverage in maternal would be out at 6 to 8 weeks postpartum, and extend that for a year. Because what we're finding is some of these women who are opioid addicted will go overdose later.
Yes.
And I think that's important for
It's
every state
critical.
to do
And if you think about us as OBGYNs, we believed 6 weeks was the magical thing, and so we had insurance end at 6 weeks, but that doesn't match actual science. The science shows us that women have cardiomyopathy within 6 months to a year later and can die. So all these other things around childbirth are still impacting your body, and there's nothing magical about 42 days.
I totally agree with that. And the risk factors that you see from maternal mortality would be age. Obviously, women are older when they have their children. Ethnicity, which you mentioned, obesity, lifestyle, which could be opioids, drug addiction, other things, preeclampsia. We know those things. But why do you see, because to me to have it almost double is one of the most distressing things with the amount of money that we put into maternal health in this country.
Right. And so we see a few things. One of them is our lack of investment in community-based organizations and hospitals. When you practice, you knew everybody around you, I'm sure, and we just don't have that kind of system anymore. So how do we have a system that values the community members who are close and understand the moms, and so really getting back to being close to that. We also increased our C-section rate, you know that. Yeah. And so a lot of women are dying from hemorrhage and other things after having a C-section. We have one of the highest C-section rates in the world, and we then export that to other countries. India starts following us and having high C-sections too. So we need to really think about why we're doing some of the choices we're doing, and this body has a greater capacity to hold systems accountable for making choices.
That was one of the other things I was going to bring up. I looked at, when I've stopped delivering babies, I looked at my primary cesarean section rate, and I was trained in Memphis, very similar to where you were in New Orleans.
Exactly.
And was 8%.
Yep.
Primary cesarean section rate. Now it's probably 30, 35%.
Exactly,
And the
exactly.
mortality rate is much higher, as we know, in cesarean births as opposed to a normal, a natural birth.
Yep.
I'd like some firm things. We did this in Memphis many, many years ago. We had neighborhood clinics for women who had a hard time getting in. This is urban areas.
Exactly.
I live in a rural area, and someone mentioned an OBGYN desert.
Yep.
I represent 4 counties, and almost 5 of them have zero obstetrical care in those counties, which means they have to drive long distances.
Right.
In Memphis, we had neighborhood clinics, and we had nurses that took care of those. If there was a certain issue, then they were sent to the hospital clinic to get evaluated. If their blood pressure was above a certain amount. That seemed to work pretty well when we took the care to, and this was 50 years ago.
Exactly, and we stopped investing in those kind of things. We stopped investing in perinatal birth workers. We know community health workers work. We know that investments in people who are closer to the community work. And then you don't have to make people come all the way downtown for a visit. We can now use technology. Telehealth is an opportunity for us to really increase access. I mean, we have so many opportunities. Sometimes we just have to allow for the room for people to build up some of the things that they've learned and that we've been doing on the ground.
Do you think, Dr. Perry, do you think that that malpractice has increased? We haven't mentioned that at all.
I know.
A lot of young
You and I could talk about this all day.
I didn't, yeah, exactly. We won't say anything bad about lawyers too much today. But anyway, I think that has, it didn't affect me much. I trained in a different time.
Yep.
But I see our younger physicians that are really impacted, I think, by that.
For sure, people quit practice because my malpractice insurance was $80,000 a year. And that was, and I had to pay that first before I could pay rent or pay employees. So the cost of how much you pay for malpractice is so prohibitive. And then we're not going to fix maternal health through lawsuits. So that is our current structure in the United States. We're going to fix this and we just sue our way out of it. And that's just not working. This is an imperative that we really come up with policies that are bigger than lawsuits to fix health.
Madam Chair, I want to thank you for having that. We could go on.
Yeah.
Carry all day.
Exactly.
I want to thank you for having this. I think we should continue this because this is a travesty in the United States to have these kinds of mortality rates. And I do hope we continue this conversation.
Thank you.
Thank you. I knew you would be interested, Dr. Crow. Ms. Fudge from Ohio.
Thank you very much, Madam Chair. Thank you all so much for being here. It's good to see my friend, Ms. Stewart. Thank you as well. It's interesting to me that we talk about many of the reasons. Now, let me just say I'm from Cuyahoga County, Ohio, and you don't need to go much further than Cuyahoga County and Summit counties in my district to see the tragic disparities in infant mortality. There are as many white addicted people as there are black addicted people. But according to Moms First, which is a home visitation program in the city of Cleveland, of the 13,872 births in 2018, 120 infants died within the first year of life. Black babies make up a little over 1/3 of all of those births, but accounted for more than 2/3 of the infant deaths. And in Summit County, the infant mortality rate among non-Hispanic black families are more than 3 times that of non-Hispanic white families. So there is just more than just what we are hearing. And I'm really glad that Dr. Rowe likes the whole concept of community health centers. We just need to fund them. Ms. Sankofa, how can we remove barriers to breastfeeding for black mothers?
I think that the reality is I think that most of the solutions exist within the communities that are having the problem. And the most important thing that I think that anybody can do is listen to the communities that you intend to serve. I used to run a breastfeeding project at a different organization, and we did implementations of community-level breastfeeding support interventions at 72 community-based organizations and local health departments across the country. And The thing that really made sense was to have a community-specific understanding, meaning you have to do some level of community assessment to evaluate what are the systemic and structural barriers that exist for that community. The problem in Cuyahoga County is not going to be the same exact problem in Memphis. And so you have to have different solutions, and I think that those solutions have to be policy systems and environmental change solutions that really look at creating spaces of continuity of care. Breastfeeding happens at the hospital. It needs to be educated prenatally. It happens in the community. And all of those different spheres and spaces where women go, they need to be interacting and speaking to one another in a way that makes sure that people don't fall through the cracks.
Thank you very much. Dr. Correa Perry, can you speak to the phenomenon of weathering and its impact on maternal health outcomes for Black women?
Yeah, so although we look fabulous, black don't crack, as we say, on the inside, the impact of racism is really bothering our bodies. And Dr. Geranimus, for about 20 years, has been doing studies to show that. We have work out of UCSF, out of UNC, that shows that the biological impact of racism on our bodies causes us to have higher rates of hypertension, higher rates of preterm birth. And so instead of looking for a pill or a shot to fix weathering, what we can begin to do is hold people accountable, hold systems accountable for things that are harming our bodies like racism, classism, and gender oppression. Yeah.
Pregnant women just don't feel it. I feel it here every day.
Yeah.
Let me, before I go any further, thank the organizations in my district that work to help eliminate these disparities. I think it's important for us to say thank you. They are First Year Cleveland, Moms First, Birthing Beautiful Communities, and Full Term First Birthday Greater Akron. It is important to know that there is help. And so often, we don't know where to get help. Because these kinds of agencies and organizations, they just get by. So it's difficult for them sometimes to let people know that they're even there. You talked, I think, Ms. Stewart, about having coverage but not access. I represent some of the best health care in the world. In the world. Cleveland Clinic, university hospitals, Rainbow Babies, and I could go on and on and on, yet my people don't have the kind of access they need. You talked about how we get people to a place of health, but it starts way before pregnancy. And so I just appreciate the work that you all do. I thank you, and I thank the chairs for having this hearing, because it is an epidemic that nobody is dealing with in any big way. So I hope that I can be helpful in some way going forward, especially because there are so many of my babies that we are losing. I thank you, and I yield back.
Thank you, Ms. Fudge. Thank you very much. Mr. Fulcher?
Thank you, Madam Chairman. And I've got a question for Dr. Perry, but I have to share my bias first. I love babies. I like all of them. And I like the name of your group, the Black Mamas Matter Alliance, and I'm sure that probably extends to the Black Babies Matter Alliance too, so that's great. We know that women of color have about a 3 times more likelihood of having an abortion than not. And that's kind of I wanted to talk to you about that, because we're confronted with a situation where, in this case, Planned Parenthood is the #1 provider of that. And just historically, they have targeted that community, the women of color community, and they provide many more abortions there than elsewhere. And that's just wrong to me. And it's just, the data is so obvious. And why women of color? And why the target there? And it just seems unconscionable to me that people are making money off that, and somehow we tolerate it. And I just wanted to get your thoughts.
So I'm not a representative of Planned Parenthood, although I work with them extensively. So I'm speaking on behalf of Gioia and not the organization. So how Black women interact with healthcare is a lot based upon the history of historical injustices and oppressions. And so perhaps instead of thinking it as they are being preyed upon by Planned Parenthood, that we are being provided a service because we don't have access to Medicaid expansion in some states. We don't have access to all the other services. We don't have hourly wage jobs that we can leave. So we don't have all the social things that people need to be able to make different choices around birth options.
The result of that is that losing babies.
Exactly. So the result of us not making choices in this building to support Black women means that Black women have to make a lot of different choices around their bodies. So if we decided that we believe that we should have access to paid leave, maybe that would impact who chooses to have an abortion or not. Like, there are choices that you all make here as policymakers that impact how we can live our lives that is much more impactful upon our lives than any one organization like Planned Parenthood. They are one small organization. You are the government. So how you decide to support women and how you decide to support Black women and listen to Black women really matters way more than what Planned Parenthood does.
Thank you, Madam Chair. If I might just follow up. And I hear what you're saying, and that makes sense. At the same time, I don't think that crosses their mind one little bit. I don't think they care. I think that their whole deal is looking at the bottom line, because that's when we get approached for funding and we get that kind of pressure. All right, I understand what the point you're making, but I just try to communicate a point. I don't think they care one bit.
So I'm going to give you a counterpoint. Our wonderful Congresswoman from Cleveland mentioned Cleveland Clinic. They choose not to open labor and delivery in the part of the city where they had their big hospital is because they don't make money there. They have a labor and delivery in the suburbs, right? So they have their hospital that's in the neighborhood that needs the most care for pregnant moms. They make a choice to say, we're not going to do any labor and delivery here. We're not going to provide services for the people in this community. So I would say that most organizations, big healthcare systems, make choices based upon money, and that's a choice that the United States has made in general around how we provide care. If we took that conversation outside of where you can make money, because I could go back and forth with you about all the systems and where they choose to put clinics, where they choose to put hospitals. Those are choices based upon money, based upon choices around Medicare and private insurance that are made here, that we can make very different choices.
Thank you, Madam Chair, and I'll close my comments with this. And thank you, Dr. Perry. I'll just say this. Let's agree on this.
Okay.
Maybe that's a two-prong approach, because I think you bring up some good points, and to the extent I and colleagues can be supportive of that, then I'm happy to try to do that. And at the same time, for those who I am convinced are preying on our community of color, I'm not supporting that. And so please know you're appreciated. Your work is appreciated, and hopefully we can work together on a two-prong approach to trying to make things better, okay?
Sounds great. Thank you.
Yield back. Thank you.
Thank you. Mr. Takano of California.
Thank you, Madam Chair, Chairwoman Wilson, and Chairwoman Adams for this critical hearing on maternal health and infant health. The United States has some of the best physicians, hospitals, and groundbreaking medicine in the world, and yet it is also the most dangerous and worst place to give birth among any of the developed countries. A 2019 report from the Centers for Disease Control and Prevention found that 3 in 5 pregnancy-related deaths could have been prevented, and unfortunately, the number of infant and maternal deaths are increasing every year. We know there's a link between having access to health coverage and the decrease in maternal mortality and severe maternal morbidity. A report by Georgetown University's Health Policy Institute found that in Medicaid expansion states like California, they have seen decreasing maternal and infant mortality rates. Madam Chair, at this moment, I'd like to ask unanimous consent to enter into the record the report from Georgetown University. Thank you, Madam Chair. My first question is from Ms. Stewart. Ms. Stewart, what benefits do you believe extending Medicaid coverage for mothers beyond 60 days will have?
Well, thank you for that, and I appreciate you raising that issue of the CDC study that said that 3 out of 5 of the cases of maternal death could have been avoided, and it could have been avoided with improved care, not having delayed or misdiagnoses, and a whole range of other issues. So we know that this issue is completely within our ability to control. We also know that the issue of maternal deaths is spread across the period of time from pregnancy, right at the time of childbirth, and then from the period of time from 1 week out from having the baby out to 1 year. When we look at the issue of Medicaid coverage, we know that for many women who actually were able to receive Medicaid coverage for the birth of their child, after several months, over 50% of them are often dropped from Medicaid coverage, which means if they have had chronic health challenges, even some that were exacerbated or any health challenges exacerbated because of pregnancy or childbirth, they are often left without coverage. And so the idea of expanding Medicaid coverage for all women and for not only during the period of the childbirth, but for women to make sure that they have the care that they need, both in terms of their physical conditions, but also their mental health conditions as well. Because a lot of the challenges that women may face often are not just as a result of issues that affect their health, maybe related to obesity or hypertension, but also due to mental health concerns as well. So we think that the ability and the need to have to extend Medicaid coverage to make sure that women have the coverage they need out to 1 year is essential in terms of dealing with the kinds of postpartum challenges that many women experience after having birth.
So again, the reasonable length of time that coverage should be extended is?
We propose, and I think there's a lot of agreement that out to a year is really important.
To a year.
A year.
What can we learn from other developed countries that have lower mortality rates? What do we know?
So I think, and I mentioned it earlier, I mean, I think there are a lot of things that we can look at. One is that, you know, a lot of countries actually have far more supportive policies for families. So issues like paid family leave, more supportive policies within the workplace, really more extended care for women, access to other alternative forms of care like midwives, and have been really important and really productive, effective ways to help women have more successful pregnancies.
Thank you. As Chairwoman Adams has stated, nursing workers that are eligible for overtime pay under the Fair Labor Standards Act are entitled to break time and a private space to express mother's milk. This is an important workplace right that helps promote the health of both the baby and the mother. Ms. Sankofa, when an employer violates a nursing mother's right to break time and private space to express milk, how can the nursing mother hold her employer accountable?
Thank you. That's actually a really difficult thing for the actual employee to do. There's a significant gap that is surfaced in terms of remedial measures related to the break time law. The employee has to reach out to the Department of Labor Wage and Hours Committee, Wage and Hours for the Department of Labor to express that to file a claim. And then the Department of Labor has to investigate whether or not there was an actual violation. And before anything extra can happen, the Department of Labor actually has to take the step to take it to court or not. And so when it goes to court, there's nothing that mothers actually get from that process typically, because it's for the break time law is not necessarily a paid aspect of that process, and so there is no actual thing that you get back, even if it goes to court via the Department of Labor. And so I think that movement to the PUMP Act is very efficient way of trying to create a space where the traditional spaces of the FLSA can be implemented so that the same type of remedial actions that exist for other violations of employee accommodations, employers already know how to work with this, and this puts it within that same level of statute within the law.
Thank you, Ms. Sankofa. I'm sorry I went over. Madam Chair, and yielding back, I just want to acknowledge the work of Barbara Anderson, a constituent of mine, who has done tremendous work on this topic as a nurse midwife who's been a scholar and researcher. So I apologize for going over, but I yield back. Thank you, and thank you for your answer, Ms. Sankofa. Very helpful.
Thank you. Thank you very much. Dr. Fox?
Thank you, Madam Chairman. Out of great respect for my colleague from Tennessee, I yield him 30 seconds.
Just very quickly, we don't have enough people breastfeeding. We have a maternal mortality rate that's too high. Why don't we take a public health approach? Remember, only you can prevent forest fires. We all remember that. If you're old enough, you do. Why don't we have a public health approach to educate the public in the country? I will bet you that most Americans have no idea that the mortality rate is that high. So why don't we look at the Surgeon General, the March of Dimes and so forth, and do a public health education approach to our people in the country? I yield back.
Thank you, Dr. Rowe. Ms. Stewart, as we like to say in this committee, states are the laboratories of innovation, most often for the better, but sometimes not so. We can learn a lot from what states are doing to address infant and maternal mortality and find out what works and what does not. What state initiatives are underway to address infant and maternal mortality? What are the preliminary results of these initiatives and programs?
Well, I actually think one of the states that's probably had the most success on the issue of maternal mortality, for sure, has been one that was mentioned earlier in California. California was one of the earliest states to actually create what essentially is now one of our maternal mortality review committees, and actually use data to actually drive decisions on where maternal deaths were happening and what interventions, working with healthcare providers, working with hospitals and others to make real progress. They have made measurable progress over many years. They still are working on some of the inequity issues that they experience. In other words, they saw large decreases in terms of maternal deaths, but they were still seeing unacceptable, and they're still seeing unacceptably high rates, not to speak for them, but unacceptably high rates among those women of color. So I think there still are, I think one of the most important things that we have not done as a country and in states is have the appropriate data, which is why I go back to the action that you all took to create maternal mortality review committees has been a huge step forward. But now that we're learning more, we can do more to actually prevent some of the causes and the underlying causes of death.
Well, thank you. And I think there has been a huge emphasis in this Congress in the last 3 or 4 years on evidence-based decision-making. We've talked about it in all areas. We want to be able to do what works instead of just throwing money at programs for the sake of throwing money at programs or thinking our district deserves a certain amount of money. We really do need to be using our scarce resources very, very wisely. Let me ask you another question, Ms. Stewart. As we consider this important issue from the perspective of this committee and examine potential solutions which are in the jurisdiction of this committee, how can employers and health plans work with providers to support decreased maternal and infant mortality? We've heard from employers about partnerships with other organizations, including the March of Dimes, to promote value-based care, reduce unnecessary interventions, increase transparency around provider quality. Are you aware of any partnerships among providers, employer-sponsored health plans, and organizations that are working to improve the quality of maternal health?
Well, I think there are a lot of employers that are becoming much more aware of some of these issues, and I think one of the things that, you all have the ability to impact is, and one of the policies that I think is most effective in terms of providing the support that often families need is around paid family leave. It's not the only thing, but it certainly is one thing that can make a big difference. If a woman has had a problematic pregnancy, if she is having to stay at home to take care of a child, she should not have to be forced to between having to return back to work or stay at home to take care of her baby and then face income interruption that could be devastating to her family. So I think the kinds of accommodations that would be provided by making sure that there is sufficient paid family leave for a woman to have to deal with maybe her own health issues or the health issues of a baby are incredibly important. I also think that a lot of employers are now much more aware of some of these issues than ever before and are open to making sure that there's more information and more awareness, as was mentioned earlier, around some of these challenges. And I think the more and more that we can pursue building the awareness and expanding public education, we have had at the March Dimes an incredible relationship with the CDC to provide broad information to the public around a lot of health challenges as it relates to maternal and infant death. We think we need to do more of that. And then the last thing I would just say is that I think a lot of employers have a vested interest in this. When a baby is born prematurely, it has a significant cost to that employer. And so a lot of employers are and even when a mother has her own health challenges, if that employer is then left without a productive worker, or if that mother dies and is no longer there are significant costs to that employer. So I think there are tremendous opportunities to go to employers and look for partnerships to expand the kind of information and access to care that women need and the families need.
As I've said before, I think that employers understand what you're talking about, and that anytime an employee is out, there's a significant loss to everyone. And so I do think there's a great deal of concern on the part of employers for their employees, and they'd like to do things that make it better for everyone concerned. Thank you, Madam Chairman. I yield back.
Thank you. Ms. Gioia Paul?
Thank you, Madam Chair. Thank you all so much for your excellent testimony. Very, very powerful. And I can tell you, as a mom myself who delivered my kid at 26 and a half weeks, 1 pound, 14 ounces, serious threat to my own mortality and certainly to theirs and morbidity. This is an issue that I've worked on myself and followed for a long time. I think we are, the richest country in the history of the world, and we spend by far the greatest amount of money on healthcare, and yet we have such abysmal health outcomes as you've gone through. And I completely agree with you, Dr. Creer-Perry, when you said that we should expect more, that we should demand more, and that we must address the maternal mortality crisis in this country, and that we have to do so by clearly calling out the racism and discrimination within our existing healthcare system that makes it so much more dire for communities of color and especially for Black mothers. So thank you for that. Let me start with you, Dr. Creer-Perry. Your testimony illustrates how for-profit insurance and payment systems have a significant impact on maternal health outcomes. Can you talk to us about how high out-of-pocket costs like private insurance premiums, copays, and deductibles exacerbate racial inequalities in our healthcare system?
Well, the data shows us that Black women, despite income or education, are more likely to die in childbirth. So that means that most of the Black women who are receiving care are not on Medicaid. They are the private insurance payers that you all have legislation power and authority over. So when you allow for those institutions to charge huge deductibles, when you allow for those institutions to say that we're not going to cover your child when your child is pregnant, you're allowing those organizations to then harm women, specifically Black women, because we're also so exposed to having morbidity and mortality in childbirth. So it's important for us to not only think about governmental insurance when we talk about this maternal mortality crisis, because all three of us sitting up here, and just as well as you, have education and access, and we still have poor outcomes, right? So it's important for us to really think about our private insurers and what the choices that they make that harm our bodies.
And can you also talk to us about the huge gaps in coverage for prenatal services, doulas, patient support for afterbirth, and home care? If we had a plan, as my Medicare for All plan does, provide comprehensive services of this nature, how would that benefit maternal health outcomes?
Because we talk a lot right now about improving doula care, and I usually hear that conversation in the Medicaid population. And once again, it leaves off that we don't cover any of these things for folks on insurance. I, as a city employee who ran a city health department, had to negotiate with the insurance company around coverage for my staff. People don't realize there's an individual who's making choices for your care at your job. They are negotiating with the insurance company, and they're deciding what they're covering. We could make a rule that they have to cover doulas, and we have to cover midwifery, and they have to cover them at parity. Those are choices that one individual at your job should not be making for you.
And if every person had guaranteed coverage of comprehensive services under a universal health care system like Medicare for All with no cost barriers, what do you think would happen to the impact on reducing or even eliminating disparities in healthcare access and outcomes?
We see a little bit of a glimpse of what that would look like in places that did expand Medicaid. We see an improvement in outcomes just with that one small ask. Even in a program that's chronically underfunded, that people don't have a lot of access with, we still see improvements in outcomes. So if everybody had access to insurance and coverage, then we would see an even bigger uptick of what we could look like as a country to the rest of the world to show that we are really all that we dream to be.
I really thank you for your testimony. I think, as people know, I've been pushing for a universal health care system because I believe it is not out of reach. It is what other countries do. We certainly spend enough money that we should be able to do it here, and that would mean that we are all guaranteed the same level of high-quality comprehensive coverage with no premiums, copays, and deductibles or out-of-network doctors. And also, by the way, a more efficient system and for our safety net and rural hospitals as well. Madam Chair, I seek unanimous consent to enter into the record a letter from a coalition of racial justice organizations, including the NAACP, LULAC, and the Black Women's Health Imperative, making the case for why Medicare for All is a racial justice issue.
So ordered.
Thank you, Madam Chair, and I just want to thank you all again for your excellent testimony and for lifting up the issues that particularly Black women and women of color, face in this critically important issue that we all need to push for immediate action on. Thank you. I yield back.
Thank you. Thank you. Mr. Johnson?
Thank you, Madam Chair. I would start by noting that yesterday, as I was eating my Wheaties, I read an excellent article by the South Dakota News Watch that was printed in my local newspaper, the Mitchell Daily Republic, and it dealt with this very issue, and I thought it was an in-depth and insightful piece, and so I would ask unanimous consent to introduce into the record, effort begins to reduce risk of death of South Dakota mothers during childbirth. Into the record.
Without objection.
Yeah, thank you very much. This is probably for you, Doctor, although if any of the panelists want to weigh in, I'd be interested to get their take as well. I was intrigued by some of the best practices that this article brought out, things that seem to me to be relatively low-hanging fruit. I'll give a couple of examples. Weighing blood-absorbing pads so that we can better ascertain how much blood loss a mother has had during childbirth. That doesn't seem very difficult to implement. Blood pressure cuffs so that medical professionals can have real-time information. So if they forget, if they miss a measurement time, they're still alerted to when that mother, when we've got a blood pressure problem. Again, I view this as relatively low-hanging fruit. When you look at the implementation of these practices across the country, on a scale from 1 being we're not doing any of them, and 10, we have perfect implementation of these best practices.
Yeah.
Where do you think we are as a country?
Oh, man, 3.5 maybe. The good news is because two, yeah. I mean, you bring up the blood loss one. So as a practice, as an OBGYN, we weren't measuring blood loss that way. You might be surprised to know that we would do things like look and say, it looks about like 1,000 milliliters. Like that's how we estimated blood loss. So it's a big shift in practice to actually weigh and measure the pads. So what you then have to do is say to the people who feel like, well, I've always done really great care, that women are dying because we are not doing this correctly as a field. This is a systems change. This is not about you as an individual and the care you provide, but a systems change. So that system shift has been difficult because people still believe in their own individual, that they as an individual provider are doing great things. So having legislation, having joint committee, having standards by governing bodies then makes for room for implementation to occur, as long as it's optional. And I'll even go back to it was exciting to have the CDC give money to states around maternal mortality, but we don't require it, so that's why you still have 3 states who haven't done it. So there are times that we need government to act to put together policies that require things like you need to count the blood loss.
Yes.
Can I add to that too? Because I think those are practices like measuring, monitoring whether or not women are hemorrhaging and how much they're hemorrhaging so that we actually know how at risk they are after they've had the baby, they go home and they're experiencing problems that were not dealt with when they were in the hospital. But the real issue is that we're not going to deal with the issue at the point of a woman almost at the point of death, right? I mean, if she's hemorrhaging to that extent, she's so close to potentially losing her life. The issue is, how do we move more upstream? How do we address these issues of women's health before they're pregnant? What we find is that increasingly more women that are pregnant have chronic health conditions. They're obese, hypertension. One of the leading causes of death for women as a result of pregnancy and childbirth are health-related, heart-related challenges. So how do we make sure that women are able to manage their health before they're pregnant so that they don't have these problems exacerbated as a result of pregnancy and childbirth?
So maybe a follow-up, Dr. Kerr-Perry. We mentioned standards and national bodies. This article talks about the Joint Commission, which I think has some oversight or engagement with, they said, about 80% of hospitals in the country. I mean, if I'm looking to some repository of best practices, if I'm looking to a source that really has it right, is the Joint Commission a good place for me to pay attention to?
So I was on the Joint Commission Task Force to create those measures, and so I think there are people in that room. The American College of OBGYN has the AIM bundles is a great place where you can look to find a repository of best practices, and that's really who, through HRSA, has been funded to build the policies out. The CDC has the Perinatal Quality Collaboratives, and they really need more funding to uplift those collaboratives. In South Carolina, I just spoke at your annual meeting around maternal mortality in South Carolina, and really having more investment in the Perinatal Quality Collaboratives would be so important, because that's, when you get the number and the data, someone has to implement it. So who's gonna say to the people in South Carolina, are you measuring your blood loss? It's gonna come from that Perinatal Quality Collaborative who needs support from legislation.
Well, thank you very much, and Madam Chair, what a important topic and what a meaningful conversation we've had. Thank you.
Mr. Morrell from New York.
Thank you. I find it completely unacceptable that more than 700 American women dying of pregnancy-related causes each year, and tens of thousands facing severe health implications. So I appreciate very much, Madam Chair, you and the ranking members for convening this hearing today. What we need to do to talk about what we need to do to protect mothers and children. There's been a lot of conversation about what goes on in other states, so I just want to just share a little bit about what we're doing in New York, if I can, get a little equal time for the Empire State. We've actually made, I think, significant improvements. We were just a decade ago, I think, about 46th in the nation, which is really obviously just a horrendous number, but we have now moved up to 23rd, at least as it relates to maternal health outcomes. We've made significant investments in the last decade. Today we have 86 hospitals participating in the New York State Perinatal Quality Collaborative, which better assesses and manages obstetric hemorrhage. Last year, we took steps to create our own maternal mortality review board, building on the success of collaborations in many other states that have been mentioned here today. But we still have a long way to go. And I note that my son and daughter-in-law are expecting a grandchild very soon, so I'm really paying attention to a lot of what you're talking about today, more than perhaps I knew about when I was an expectant father. But I do, after the testimony, and I do want to get to a couple different questions. If I might, first, Ms. Stewart, obviously it's been talked about the estimated 60% of all maternal deaths could have been prevented. I'm interested, I understand in the state of California and elsewhere, hospitals have found success using simple innovations, hemorrhage carts, quantitative blood loss, elective C-sections reductions, all methods have resulted in lower rates of death, as I understand, among pregnant women in hospitals. And I'm just trying to understand what are some of the changes that can be made among the medical community that relates to providing care during pregnancy and delivery first and foremost. I know that there's the post, but I'm just curious, during delivery and immediately after, during pregnancy, delivery, and then immediately after, if you could talk about some of those impediments or barriers.
So I think one of the things that we have to realize is that women have been having babies for a long time before hospitals existed.
Now, that may be the truest statement ever said in a congressional hearing.
This has actually been going on for a while, and even before hospitals were even around. And what existed, now, there were some not great outcomes before, but and hopefully our medical community has really sought to look at ways it can improve those outcomes over time. But one of the things that we found are some unintended consequences. One of the things that Dr. Correa mentioned is dramatic increase in C-sections, right? So 1 out of 3 deliveries now is by C-section. And we know that puts that mom's health at risk, right? And
is that, I'm sorry to interrupt, but in recent years, has that number gone up or down?
It has been going up.
Still continues?
It has been going up. What we actually at the March Times had a big influence on the number of elected C-sections, which we actually were able to see a decline in elected C-sections, especially during the period of time before this last 4-year period of an increase in preterm birth rates. We were actually seeing a decline, and we think a big contributor to that may have been a reduction in elected C-sections. But we're seeing overall C-sections increase, and it's not often, fully elected by the mom, right? One of the things I think that we can really look at is the fact that we can go back to some practices that actually did work for us in the past, before we had a very medicalized process of delivering babies, right? So in New York, you all are doing a whole experiment on doulas as a part of the Medicaid program. We think and we encourage healthcare professionals, medical professionals, doctors, to have better relationships with midwives and with doulas. We know that studies have shown that doula care can often reduce the level of C-section, can increase and improve health outcomes for moms and babies. We think that if these kinds of services were more available, maybe in addition to their traditional medical care, we could probably see some outcomes improved over time. Those are just some of the things that.
Great, thank you. And I only have a few seconds left, but I did want to hear Dr. Correa, the issues of unconscious bias related to both gender and race affecting pregnancy-related care. Could you just talk a little bit more about that?
Yeah, I have the pleasure of working with staff there in New York around this work, and they are doing some trainings with their staff because what we recognize is this unconscious bias makes us do things like if we believe it's a black woman and their blood pressure is 160/90, the hospital will say, oh, but they all kind of run high, so they won't treat it. And then the next thing you know, that woman is seizing and in the ICU. So the bias around believing that we all kind of have hypertension when we don't is killing people. So those are kind of the important things for us to be able to unpack.
Great, thank you. Thank you, Madam Chair. I do ask unanimous consent to submit into the record a letter from Johnson & Johnson applauding this subcommittee's leadership in addressing the urgent health crisis that affects families around the country and expressing their commitment to the goal of eliminating preventable maternal deaths globally.
Without objection. Ms. Weil from Pennsylvania.
Thank you, Madam Chairwoman. First, I just want to thank this panel for not only the content of your written testimony, but the passion that you bring to this subject. Very easy to listen and absorb what you've said, and it's just such an important subject. I feel as though in a country where we say that we value family values so much, that we often miss the boat when it comes to policies and accommodations and efforts that need to be made to truly promote family values. And of course, maternal health is key to that. And I appreciate the systemic approach that all of you seem to have adopted to the problem of America's maternal and infant health crisis, because it seems to me, both in my own thinking, but also you've fleshed it out for me in your testimony, that it really is has to be a holistic approach. It has to start very early in life. It has to start with education. It has to start with making sure that young women and men are able to get a good education so that they can go on to get good jobs where they have more flexibility and hopefully better health care benefits and that kind of thing. We have to make sure that our workplaces are safer and that workplace accommodations for pregnant women and new moms are made. We need improved health care from all perspectives, not just pre- and postnatal care, but overall preventive health, whether it be blood pressure checks, routine mammograms, immunizations, gynecologic care, and that kind of thing. So with all of that said, none of that was a question, but I want to ask, and I could ask any of you these questions because you're all very well qualified, but let me just start with Dr. Perry. I won't ask it as a leading question. Do you believe that better access to contraception is an important component of women's health?
For sure. We know for sure that if you don't have access to be able to make choices around your body, that you can enter care later, you can enter care sicker, that you are not making fully informed choices for yourself. And so that I love that you use family values. So the value of valuing what the woman wants and valuing what her needs are and meeting her wherever that is. And you can have your own beliefs in your own house, but our job really is to support what people believe for themselves and what they want for themselves.
And before we even get to the issue of contraception, I assume you feel the same way about sex education, both in the schools and outside the schools throughout our community.
Yeah, and it's important as a person who, as a mother and as an OBGYN, so many patients don't know basic information about their bodies, and we're expecting them to navigate a world where we haven't given them the tools to be able to do that.
Right. And same thing with the protection against intimate partner violence.
Yes, for sure.
The need, and Ms. Stewart, I'll address my comments to you, just because I see you nodding. That's a similarly important component of this. Am I right?
It is important, and I just want to mention one thing on contraception too. Science tells us that one of the most effective ways to reduce preterm birth, if a woman has had a preterm birth already, is to ensure that there's appropriate birth spacing, and that means that a woman has to be given the ability to make the choice as to when she has a baby, and certainly ensuring that there's an 18-month gap at least between the time when she's had a baby and the time that she becomes pregnant again has been proven to actually reduce the risk of a subsequent preterm birth. But we also know the protections around intimate partner violence are really important. I mean, we have seen an increase. I live in Maryland. We saw a dramatic increase in the kind of violent activity targeted towards pregnant women, and our state took action there. And I think it's important that at a federal level we address the fact that too many pregnant women are subject to the kind of violent treatment by their partners or significant others that really put them at risk and then also put their babies at risk too.
So Dr. Perry, switching back, am I correct that not all health plans, even under the ACA, cover the services that we've just talked about?
For sure, and it's really frightening to think that we've made so many steps forward, but we keep getting steps back. And so really making a commitment for all health, for people to have access to all the services would be important.
So my colleague, Mr. Fulcher, across the aisle, commented on Planned Parenthood. And my question to you is, what is the role of community health centers and places like Planned Parenthood to fill these gaps in services?
Right, so because we do not have a universal health care system, we need players like Planned Parenthood and others. We need organizations like federally qualified health centers. Here in DC, there's an FQHC that has a birthing center inside of a federally qualified health center with a Black midwife, Ebony Marcel, who's running the center, so we have full range of reproductive options. Also in Memphis, there's an option. So we need all the Planned Parenthoods, we need the clinics, we need quality care provided for people in their neighborhoods who, and all their needs met across the reproductive spectrum.
Thank you very much. My time is up. I yield back.
Thank you. Ms. Macbeth from Georgia.
Thank you, Chairwoman Adams and Chairwoman Wilson. I appreciate you both for being so instrumental in highlighting the need for transformative maternal health in this country. And I also want to thank the panel for coming to address Congress on this very, very pressing issue. Now, we all know the statistics, so we don't have to go over them again. We've all seen the failure to make progress on this problem. That's the reason why you're here today. This problem runs far deeper than many want to even acknowledge. And we have a responsibility to these families to make sure that their safety and the health is the #1 priority. Research is clear. Access to care and other socioeconomic factors play a significant role in maternal mortality rates in Georgia and throughout this country. And actually, Georgia has the highest, second highest maternal mortality rate in the country. Dr. Correa Perry, what should we be doing to ensure that women have access to not only the health care, but also the other supports that they need to be healthy during pregnancy, childbirth, and postpartum?
Well, it's exciting to see, thank you, that there's a move to extend Medicaid for a year. I think Georgia is one of the states that could really benefit from that. Having not done Medicaid expansion, really letting the science show us that you need to have insurance for at least a year after you have a baby, so that would be an important move. I think also in Georgia and other states, looking at our policies around access to work leave, it's not even just when you have the baby. If you are a high-risk pregnant person, you need to go to the doctor more often. If you're choosing between your hourly job and being able to make twice-a-week appointments at a doctor's office where you sit for 4 and 5 hours at the Grady, right? You don't have time for that. You have to go to work. And so when do we make room for paid leave and structures that allow for people to be healthy, not just when the baby comes home, but caring about mom while she's pregnant?
Thank you for that, because I was a high-risk pregnancy myself and actually had to take short-term disability because when I was working as a flight attendant, there were no particular considerations that were made for us as pregnant women. So I had to go into short-term disability just to be able to make sure that I brought my son into the world. A few months ago, I worked with Representative Gwen Moore, Tom Cole, and John Katko to introduce the Family Violence Prevention and Services Improvement Act. As you know, FISPA provides necessary funding to help survivors of domestic violence, and it should not go unaddressed today that there truly is a correlation between intimate partner violence and maternal health. Dr. Correa Perry, can you share more about why pregnancy puts women at a higher risk of experiencing intimate partner violence?
Yes, so we know that the stressors that are impacting mom are also impacting dad. So we're going to want to move to a space of restorative justice, right? How do we think about intimate partner violence in a lens of, if we don't provide supports for families, for people of color across the United States, when a mom gets pregnant, you're gonna see dad act out. You're gonna see the partner act out and become more violent because they don't have the resources they need and they feel very, that they can't meet the needs of what they're supposed to have done. If we really want to improve intimate partner violence, if we really understand why it happens, that people are not just mad and sad and acting out, that they're a part of a larger system, then important for us to invest in both moms and making sure they're safe, and really thinking through, how are we educating our sons? I have two. What are we doing around people and their access to how they think about pregnancy and birthing in their communities?
So let me go on and ask you, what are some of the health consequences of intimate partner violence for pregnant women and their infants?
We know in some states it's one of the top leading causes of maternal mortality, right? So once, in our own state of Louisiana, my home state, so we could look and see a policy choice. If you say, if I call the police, if I live in HUD housing or in Section 8 housing because of intimate partner violence, I can get kicked out. When I'm pregnant, that rule makes me at higher risk of actually dying, right? Because I'm afraid to lose my place. I'm not going to call anybody to come. And so that's a policy change that improved. So we lobbied, or we advocated for getting rid of that rule, that people could not be kicked out of Section 8 housing because they're calling the police for domestic violence. That improved the outcomes for Black women who were pregnant in the state of Louisiana. So those are the kind of policy choices that are not around individual choices, but you're putting people at risk of harm when you create solutions that don't think through what will happen to someone who's impacted. So morbidity and mortality, having risk of death is the highest risk that you can have, and it's really high from during pregnancy.
Thank you so much. I yield back the balance of my time.
Thank you. Ms. Underwood of Illinois.
Thank you, Madam Chair. On January 28, 2017, 3 years ago from today, I lost a friend. Dr. Shalon Irving was a classmate of mine at the MPH program at Johns Hopkins University. She went on to become a CDC epidemiologist, a lieutenant commander at the U.S. Public Health Service, Commissioned Corps. She was highly educated, financially secure, surrounded by a strong network of family and friends. She was covered by quality health insurance. She's a Black woman, and she lost her life 3 weeks after giving birth to her baby girl, Soleil, her first child. 3 years after that tragedy, we are here to address a crisis that cuts across education levels, income brackets, geographic regions, and type of insurance. Moms and babies are losing their lives at unacceptably high rates in the United States, and families like Shalon's are left picking up the pieces. The name of today's hearing is Expecting More. And when it comes to America's maternal and infant health crisis, we need to expect more. We need to pay more attention, take more action, and make more progress. Ms. Stewart, through your work leading the March of Dimes, you've heard too many stories like Shalon's in America. Why are protective factors like education and wealth failing to insulate American moms from elevated risk of maternal mortality and severe morbidity?
So first of all, I'm very grateful that you tell that story and that you celebrate the life of your friend who unexpectedly and wrongfully is passed away and unfortunately is no longer with us. And I think the point you're raising around the maternal mortality rate for Black women, as it relates to no other issue other than the racism that they probably experience as a result of their healthcare experience, is really one of the most critical issues that we have to talk about in this country. The fact that we can look at an educated Black woman and she dies at a rate that's 5 times more than her white counterparts is just simply unacceptable. And if it's not due to their income level, it's not due to education level, it's not due to medical coverage or healthcare coverage or insurance or all these things, then what else is it? It has simply to do with how they're being received and treated by the system, where they're expecting to receive quality care and the system is failing them. And so I think part of what we're doing at the March of Dimes is acknowledging and working with many partners to say, what can we do as one participant in the system to change these kinds of outcomes and to help the system realize that there is implicit bias in the system, that medical providers, though they don't intend to, are making judgments about Black women, and are then therefore causing Black women to receive inadequate care, often putting their lives at risk. And so part of what we're doing, just one of the things that we're doing is, in addition to having an entire health equity approach to our work, is looking at certain programs like introducing an implicit bias program. Dr. Correa Perry talked about the work she's doing in that space. We've worked with an organization to create a whole new implicit bias program for many of our hospital and other healthcare provider partners to make sure that they are aware of the implicit bias that they may be experiencing on a daily basis, that it's actually influencing the lives of the patients that they're attempting to serve.
Yeah, putting their lives at risk.
Absolutely.
Earlier this month, the Commonwealth Fund published a report showing that the Affordable Care Act narrowed racial and ethnic disparities in insurance coverage. And we know that in the context of today's hearing, coverage leads to better outcomes, for moms and babies. And yet, as we speak, the Affordable Care Act is being threatened by a Republican repeal lawsuit. Ms. Stewart, what is at stake with this reckless attack on health care, and how could it exacerbate existing racial and ethnic disparities in maternal and infant health outcomes?
So we know that the ACA has been an incredible support to expanding coverage for so many women. And it's especially true for women of color who have, where their rate of women that have qualified under ACA has it's grown at more than twice the rate of women overall between the period of 2013 and 2015. And what this has been doing is allowing women to access the care they need. Again, to talk about this issue is really to underscore the importance of women getting the kind of preventive care they need before pregnancy and during pregnancy. The fact that they now, many of these women of color, have more access to the kinds of coverage that is available to the ACA, especially because of essential health benefits being involved. So no cost sharing applied to all kinds of well women visits, all kinds of prenatal care visits that are really essential and incredibly important. You know, we still look at prenatal care visits and still know that too many women are not able to access the kind of prenatal care that they need. If ACA is removed, if they don't have access to being able to get the kind of health coverage that the ACA provides for women, especially women of color, we are likely to see a worsening of outcomes for those women and a worsening of outcomes for their babies. It simply would be devastating to so many of the families that we're trying to serve.
Thank you. Madam Chair, my time has expired. I could sit here all day and talk about this issue. It's so important. Thank you for your leadership and for convening us here today. Thank you to the witnesses, and thank you for being a member of the Black Maternal Health Caucus.
Thank you. Dr. Shalala.
Thank you very much, Madam Chair. Let me congratulate Representative Adams and Underwood for their leadership of the Black Maternal Health Caucus. Those of us that joined it, we have a simple goal: save Black women's lives and tackle racial disparities in healthcare. My colleague from Florida has already indicated the statistics in our own Miami-Dade County, which the racial disparities are simply criminal and not acceptable. But the root cause of the statistics for maternal death are often misunderstood. The public image of maternal death is a woman who has a medical emergency, like a hemorrhage while in labor, rather than 4 out of 5 of these deaths happen in the weeks and months before or after birth. And ensuring women have access to comprehensive and affordable care during and after pregnancy is absolutely critical. I do want to put on the record that over 96% of Planned Parenthood services are really in women's health. It's to help women be and stay healthy before, after, and between pregnancies. And Planned Parenthood does not, unlike the Ms., make money on abortions. Planned Parenthood is supported by charity and by contributions from millions of Americans. I want to ask a very specific question, because what I'm interested in is in federal programs. We've talked a bit about federal programs and about filling in the gaps. We know that chronic medical conditions, including obesity, cardiovascular disease, hypertension, are chief contributors to maternal mortality. Yet, we've also heard that federal programs are not designed to support women's overall health before and in between pregnancies. Medicaid's pregnancy coverage only extends to 60 days of postpartum. WIC's postpartum coverage only covers 1 year for breastfeeding women, and the ACA has real limitations, including those that were pointed out on women under 26. We need, if we're going to write a comprehensive bill here, it's really going to be a bill that fills the gaps while we're waiting for universal, seamless health coverage that would make a difference for all Americans. So I'd like to ask each of you what your top 2 or 3 recommendations would be specifically on program supports and program improvements, because what we might do is simply go through all the programs and do a comprehensive bill that fills in the gaps on the programs. That would be, I think, a life-saving step for all of us. Let's start with Ms. Stewart.
So I guess a couple of things I'll mention. I think one of the most important things that can be done is this expansion of Medicaid up to 1 year. I think the fact that we have too many women that are being dropped from coverage within 60 days to several months after childbirth is a real challenge, and it's inhibiting their ability to seek the kind of continued medical care that they need. A couple other things that I'll mention, though. I think it is really important to look at what Medicaid covers beyond just the medical care for the healthcare provider. We know that access to Medicaid reimbursement for doulas, for midwives, and I would even say we're involved in a program called that's involved in group prenatal care. That's an evidence-based program. It is shown to reduce the rate of preterm birth by up to 30%. But in many states, we're not able to receive Medicaid reimbursement. But we know that that's the kind of care that women often need beyond just their traditional health care. So there are things like that. The last thing I'll just mention is we do have some gaps and some barriers. For example, around newborns being added to health plans, we find that there are too many families who have a 30-day window to add their newborn to a health plan and often miss that window. And then as a result, especially if their baby's in the NICU, they may be subject to exorbitant healthcare costs because they missed that window. And so closing that gap would be also very important.
So I'll go by agency. So HRSA, you could improve how we do Healthy Start National Healthy Start. It's a great program. It's community-led, community-driven. CDC, we can bolster up the PQs, the Perinatal Quality Collaboratives. They are the driving force of how we're going to get policy done. We have not invested in those. And then in NIH, you can uplift the Office of Women's Health. It's just the office, so it has no budget. So we think women are more than half of the population, and yet we don't have any dedicated institute or center for women's health. So it would be exciting to see you all look at these big, larger institutions and how you could change them. And really investing in community birth workers on the ground, lay folks who have been doing the work in the community for a long time. In the education policy, we wanted an education plan. Really, Black Maternal Health Week is coming up, so there'll be a lot of investment April 11th through the 17th, looking at all the folks on the ground who are doing work.
Thank you. Thank you very much. Mr. Levin of Michigan.
Thank you very much, Madam Chairwoman. It's an honor to be here with the chairwomen of these subcommittees, with Congresswoman Underwood. I thank her for her leadership, and with all three of you to talk about this incredibly important issue. It is simply outrageous and unacceptable that so many women and babies of color die at disproportionate rates in this country. And we need to be able to talk about racism in this country. I want all of my white siblings in spirit who may be freaked out, if I can just speak plainly, about being called a racist or worried that they might be whenever we talk about racism. Look at this situation. This is structural racism in our society when people like Congresswoman Underwood's friend die who have every advantage in life. There is no explanation but structural racism. So let's all take a deep breath, relax our shoulders, and get on with the conversation, because we just commemorated Holocaust Remembrance Day, and we say never again. And what does it mean? It means we must not be silent in the face of injustice. This is clear injustice in our society, and we all have a role to play, and none of us can be silent. Now, Dr. Correa, I'm worried I'm going to get in trouble with you. I was not planning on raising this, but I think your very first answer to a question was about midwives. So I have 4 kids, and we had home births with midwife, but it was not legal in Maryland. So we had illegal home births with the lay midwife. So here I am confessing. Kobe was born 26 years ago. Yeah, I hope so, Mr. Chairman. So, and at the same time, I'm, I think, the only member of this body who has run a state workforce system. So I feel personally responsible for. So talk to me about the training at HBCUs, at other institutions, what do we need to do to train more midwives? Because it is certainly a crucial part of the answer here.
Thank you. In the same way that you want our colleagues to not have their shoulders raised when we talk about racism, which is what I have to do a lot with folks, I have to have my colleagues in OBGYN not have their shoulders raised when we talk about midwifery.
So I thought I might get in trouble.
No, actually my shoulders are relaxed. I'm good because I don't feel threatened. We need this. Every country that has better outcomes than us has a much more robust midwifery workforce. They have invested in training women across the country who actually are doing the births. We provide care in an ICU that could be done like you did at home. And that's just a fact. And we are afraid of change, but that fear is harming Black women. And actually, Black women are overperforming their counterparts when it comes to home birth and having a hospital birth because of our fear. Imagine going into Auschwitz without Auschwitz ever having apologized and saying, you're now supposed to take care of me and provide my health care. That's what happens to Black women when we go to the hospital. The same hospitals that for generations harmed us now are saying, come, we're fine now. We've never have acknowledged J. Marion Sims, never having acknowledged the history of oppression, and we're just supposed to trust you because you're nice.
All right, so I'm going to count on you to follow up with me and as a member of this committee, so what specifically I can do on that.
Right.
Ms. Sankofa, protections entitling nursing workers to have break time in a private space, right? It's tied to nursing a child and last only for a year following the birth of a child. So in my last minute, I want to ask you, should we rethink these policies? For example, a woman may be lactating after her baby's been adopted. For her health, shouldn't she have coverage? After a stillbirth. The time limit, I mean, my wife breastfed way past 1 year. So are these limits too narrow and inappropriate?
I think that these limits are put in place to really create an opportunity to have deep buy-in from all members so that we can move the legislation forward. But when we look at preterm birth rates, when we look at infant mortality rates, I think that a person who is pumping to provide milk for a baby who is not their own, but who may be preterm, I think that's something very, very important as to consider as a more systemic policy solution, because not every woman chooses to breastfeed. Maybe there are systemic barriers for her that make it unavailable, but if milk can still be available, that's a thing that we should definitely consider.
Outstanding. Thank you. I yield back, Madam Chairwoman.
Thank you so much, Mr. Levin. Ms. Stevens?
Thank you, Madam Chair, and thank you to our expert witnesses for your brilliant and elucidating testimony and for your comments here today. We have an emergency going on in America right now. The U.S. has the worst maternal mortality rate among developed countries, despite an improvement in global maternal mortality. This is what we are talking about here today. This is what this conversation is about. From the halls of the United States House of Representatives, I can't think of a more important topic, because for every woman that has lost their life, for every family bearing that burden, for every woman who's come too close to losing her life, crying out in pain, this is senseless, and these are injustices. And we talk about life being precious. I cannot think of a better instance of the sanctity and preciousness of life than this, than the life of the mother. We are here for the voiceless. Thank you, Ms. Underwood, for your leadership in forming the Black Maternal Mortality Caucus, because it is high time for these issues to come to bear. It is high time for this to be on the national news and in every family's household, thinking and talking about this and what we're going to do. Thank you, ladies, for your leadership. Ms. Stewart, you represent a phenomenal organization. It's in every community's hearts, and in our states, and it's on our mind. And we know about 1 in 33 children born in the United States is born with an anomaly, a congenital anomaly. And, they're required to go through various surgeries on occasion. We're thinking about the cleft palates. Could you just describe some of these challenges that families face in affording this important care, and also legislation that I'm a proud co-sponsor of, the Ensuring Lasting Smiles Act, and how that would maybe make a difference, Ms. Stewart?
Sure. Thank you for that.
Thank you.
And we agree
Thank you
with
for your
all of your
leadership.
comments. This is really an important issue that often doesn't get discussed. And we talk a lot about maternal deaths and infant deaths. We don't often talk about when pregnancy doesn't go as expected, the long-lasting health impacts that a child has to deal with and what families often have to deal with. And one of the things that is really a big challenge for too many families in this country are the number of children that are born with these kind of congenital anomalies or birth defects. And about 4% of all the children in the U.S. are born with these birth defects. Again, the March of Dimes has spent a lot of our history trying to deal with eliminating birth defects through encouraging women, for example, to take folic acid to deal with preventing certain birth defects. But the Ensuring Lasting Smiles Act is really a piece of legislation that we support strongly with about 30 other organizations. Right now, what it is intended to do is ensure that all private, group, and individual health plans cover medically necessary services. And what we know is that there are many plans that do actually provide for coverage for medically necessary surgeries and other kinds of treatments that should be made available to children that are born with these kinds of birth defects. But we are hearing that there are too many instances in which some coverage is denied, often because insurance companies will claim that a certain kind of surgery, especially dental surgeries is where this happens a lot, are more cosmetic in nature. When we know, in fact, a baby that is born with a cleft palate, for example, will have extreme difficulties with breathing or eating and really living a normal life. And so what we're trying to do with this legislation and asking you all to do is consider the fact that there should not be any family that's denied coverage or having to assume too much in terms of costs to make sure these kinds of services are available.
It's just, your leadership's been phenomenal. Madam Chair, I have a letter to submit for the record from the National Foundation for Ectodermal Dysplasias. And with my remaining time, I'd like to just get one more question and cede my time to Congresswoman Underwood.
Thank you, Congresswoman Stevens. Ms. Sankofa submitted an excellent written testimony that spoke about the Pump for Nursing Mothers Act, a bill that fixes a legal glitch that currently prevents millions of middle-class moms from reentering the workforce after giving birth. Madam Chair, I'd like to ask unanimous consent to submit for the record a letter from more than 100 organizations endorsing the Pump for Nursing Mothers Act. Thank you, Madam Chair. Thank you, Ms. Stevens, and I yield back.
I yield back the remainder of my time.
Mr. Scott, Chairman Scott.
Thank you. Ms. Stewart, it's good to see you again.
Good to see you.
Many of the witnesses have talked about the substantial number of deaths that are preventable. Can you describe the ultimate cost to the healthcare system of the initiatives that would prevent many of these deaths?
So according to the CDC, about 3 out of every 5 of these deaths are preventable. It is a lot of the deaths that they see as preventable are often due to misdiagnoses or delayed diagnoses, and a lack of adequate care that's being provided to those women. One of the things, I don't have the exact numbers, I can get you the exact numbers, but one of the things that could be very helpful is when women show up at a hospital, for example, to deliver their baby, there should be the proper protocols in place. And some of those protocols come from something that Dr. Correa mentioned, which are the AIM bundles that ACOG and others have been promoting. And that is to ensure that hospitals have these improved bundles of care, protocols of care, that would prevent these kinds of deaths from happening. So for example, when a woman is hemorrhaging, how do you deal with hemorrhage and how do you deal with it in labor and delivery when that typically hasn't been a place where you've seen a lot of hemorrhage? How can you change practices so that so those kinds of deaths are prevented? There are probably some dollar amounts attached to it. We can follow up and get you that, but I do think that those are some of the things that are
things
important.
like doulas.
Have you studied those to see whether they save more money than they cost?
Absolutely. There have been studies that show that doulas and midwives, but especially doulas, can reduce can reduce and prevent unnecessary maternal deaths, can actually improve birth outcomes, can actually make sure that mothers are safer and have healthier pregnancies.
And a lot of the provision of prenatal care will reduce the incidence of low birth weight and ultimately save more money than it costs?
Prenatal care, and then what I think we ought to look at is in places that we've looked at the March Dimes, these maternal care deserts where there isn't traditional prenatal care, how can things like telemedicine and other kinds of services be made available? And those are some of the gaps that we see that should be addressed.
Now, do you have data that show that the prevention initiatives actually work?
We do. I mentioned one earlier, in addition to some of the studies that reference around doulas. Some of the areas around group prenatal care are evidence-based, have been shown to reduce preterm birth by 33%. So we know that has a measurable impact in improving lives and saving lives and producing better health outcomes as well.
And what kind of initiatives before pregnancy, you mentioned folic acid, before pregnancy and after birth, what kind of initiatives can be helpful?
So I think a couple of things. One is that really adequate, good prenatal care is really important. But what I would say is even before pregnancy, a woman has to be able to be as healthy as possible. One of the things that we're seeing that really is affecting some of these outcomes is that women go into pregnancy with many more chronic health challenges than existed in the past. So having a woman being able to have the health coverage that she needs to address obesity challenges, hypertension challenges that she may be having, so that she improves her health before she's pregnant, we know can have measurable impact, as well as support that she may need in the postpartum era, especially postpartum period, especially around not only her physical health, but also her mental health as well. And that mental health coverage needs to be available throughout her period of time before, during, and after pregnancy.
Thank you. Dr. Correa-Perry, my colleague, Representative Macbeth, mentioned the Family Violence Prevention Services Act is also in this committee. Can you talk about the services that can be, federal services that can be provided that would have the effect of reducing violence and how that would reduce maternal deaths?
So we have a real gap when it comes to intimate partner violence as far as policies, places for people to go if they're in danger. So providing support for cities like my own of New Orleans to have housing and have availability for victims of domestic violence would be really important. Having policies that allow for safety for moms inside of workplaces, those are all really important. So there's a direct tie between the elevated risk that someone has in the world when they're pregnant, when it comes to intimate partner violence, and the ability to mitigate that risk through federal legislation.
Thank you, Madam Chair. I'll yield back.
Thank you, Mr. Scott. Ms. Bonamici?
Thank you, Madam Chair. I really appreciate this conversation. Thank you to our witnesses for your expertise. I think it's been a difficult but very important conversation to hear that we are regressing as a country when it comes to maternal and infant health. The well-being of mothers and babies are sort of fundamental measures of any nation's development. And to many Americans, I think the statistics that we've heard today might sound like they're coming from a different country or a different time. But it is a reality that we have to face. So we must face it. We must address the failings and improve outcomes for all families. And we've touched on several policies. Particularly, want to point out the inexcusably stark disparities for racial minorities. I'd like to emphasize a point made by several of the witnesses that we can improve the likelihood of healthy births even before pregnancy. Access to comprehensive reproductive health, including contraception and prenatal care, empowers women to make decisions about when and in what circumstances they choose to become pregnant. I'm currently working to update legislation I introduced last session, the EQUIP Act, that will encourage healthcare providers to routinely ask women of childbearing age about their intentions regarding pregnancy and to provide appropriate care in response to those conversations. March of Dimes was one of the organizations that endorsed the legislation because these pregnancy intention screenings improve the likelihood of healthy births. It's kind of a win-win because it's good for maternal health and it also reduces unintended pregnancies. And Some of you might have noted that Oregon was the only state that's got an A- in the March of Dimes report. In all fairness, we don't have a lot of racial diversity, but we also have many clinics that are using the sort of one key question, pregnancy intention screening, and we also sort of aggressively expanded Medicaid. We have coordinated care organizations. So we're doing a good job in many ways, but there's still a lot of work to do. We have to make sure that we're addressing those implicit biases. Dr. Correa, you spoke about positive health outcomes being dependent on implementation of all sexual and reproductive rights. Can you talk about how those rights might not be respected in healthcare settings pre-pregnancy and how policies can take that into account?
So I usually, when I'm doing data, I point out that although the United States is the worst in the world when it comes to maternal mortality, and Black women are dying at 3 to 4 times the rate, that also means a lot of white women are dying that should not. And places like Oregon give us an example of what we could do better as a country if we invested in everyone and invested in things like insurance and other things. So it's important for us to think about when you restrict access to contraception. So we have data, my colleague Maeve Wallace and others, where the places that have more restrictions on access to contraception have the worst outcomes for maternal and child health. Right. So when they say language around we're making things safer for moms, you're actually making things worse. So the data is the opposite of this narrative around safety. So restrictions for sex education causes harm, causes death.
Absolutely.
Restrictions for access to birth control, for LARCs, for abortion, all those things cause harm and cause death. The more you put policies in place that are barriers, the more that women and children are more likely to die.
Right. Our legislature, with a bipartisan basis, passed legislation to fill contraception prescriptions for a whole year rather than short term, which my daughter really appreciates.
Yes.
So I recently visited a WIC clinic in Washington County, Oregon, and saw firsthand how important these services are for women and families who want to give their children a healthy start in life. I just want to mention, in light of the public charge opinion from the Supreme Court yesterday, I think we're going to see more and more families afraid to reach out for services. But WIC serves almost 15,000 people countywide. 79% of clients are working families and 22% are pregnant. We know that this nutrition, education, and connection is beneficial in terms of improving birth weights and reduction in premature births and fewer infant deaths. Ms. Stewart, studies continue to confirm WIC's role in reducing the likelihood of preterm birth. Only a slight majority of pregnant WIC recipients, just a little more than 53%, are certified for the program in their first trimester. Do you know why this is, and what can we do to better encourage certification of pregnant women?
A lot of people are very shocked when they find out how important WIC is in terms of serving pregnant and postpartum women, infant, and children younger than the age of 5. Almost half of the 4 million babies that are born in the U.S. Have been able to access WIC, and so it's an important program. We do think that having more access and having more community workers and community access to make sure that women understand how to overcome the barriers to become eligible for WIC is really important. WIC has proven to be one of the most effective evidence-based programs to ensure that, to your point, that again we can improve health outcomes, reduce infant mortality, reduce the risk of preterm birth. We're strongly in favor of expanding and improving access and looking at ways in which to improve those community access points as well.
Thank you. And I see my time has expired. I just want to say how important paid family leave is, that we are the only industrialized country to not have paid family leave, and what a difference it makes. My state, at the state level, passed paid family leave, but we absolutely must, as a country. It's shocking that so many women go back to work within just a couple of weeks. I was fortunate. With my first child, I was able to take 6 months off. Most women can't do that. And I still, had to explain to people why I needed to take a break to go pump in the restroom. And so, having paid leave really makes a difference for a healthy start for children and families. And I've gone over my time, so I yield back, Madam Chair. Thank you very much.
Mr. Scott, Dr. Chairman Scott. Ms. Underwood, you have.
Yes, thank you, Madam Chair. I request unanimous consent to submit a written testimony from the American College of Obstetricians and Gynecologists for the record.
Without objection.
Okay, thank you so much.
Mr. Scott.
And Madam Chair, I ask the unanimous consent to introduce into the record a report from the Institute for Gender and Culture of the Black Women's Blueprint entitled "The Sexual Abuse to Maternal Mortality Pipeline."
Without objection. I remind my colleagues that pursuant to committee practice, materials for submission for the hearing record must be submitted to the committee clerk within 14 days following the last day of the hearing, preferably in Microsoft Word format. The materials submitted must address the subject matter of the hearing. Only a member of the committee or an invited witness may submit materials for inclusion in the hearing record. Documents are limited to 50 pages each. Documents longer than 50 pages will be incorporated into the record by way of an internet link that you must provide to the committee clerk within the required time frame. But please recognize that years from now, that link may no longer work. Again, I want to thank the dynamic witnesses for their participation today. What we have heard is very valuable. Members of the committee may have some additional questions for you, and we ask the witnesses to please respond to those questions in writing. The hearing record will be held open for 14 days in order to receive those responses. I remind my colleagues that pursuant to committee practices, witness questions for the hearing record must be submitted to the majority committee staff or committee clerk within 7 days. The question submitted must address the subject matter of the hearing. I'll now recognize Workforce Protections Chair Adams for her closing statement.
Thank you, Madam Chair. I want to join you in thanking Ms. Stewart, Ms. Sankova, and Dr. Correa Perry for their compelling testimony today. I also want to thank my colleagues for coming together for this bipartisan hearing. Today's discussions confirmed what mothers and communities across the country have long known. Our nation's maternal and infant health is in crisis, and the federal government must do more to stop it. And to that end, we must advance proposals that address disparities in maternal and infant health and expand access to health care and nutrition. Further, we must ensure that our nation's workplaces provide critical supports like designated pumping breaks for pregnant workers and new mothers. In closing, I'm grateful that we could reaffirm today that maternal and infant health are not partisan issues. And each of us here agrees that we have a shared responsibility to serve our constituents by supporting affordable, quality maternal and infant care. I look forward to working with my colleagues to ensure that any mother, anywhere in the United States, can receive the quality care and support she needs to navigate a healthy pregnancy and raise a healthy child. I'm a mother and I'm a grandmother, and so I look forward to having some great grandchildren one day. But before I yield, I'd like to enter into the record a statement from the organization, A Better Balance, in support of today's hearing and federal solutions to improving maternal and infant health outcomes among women of color.
Without objection.
I now yield to my esteemed colleague and chair of the Subcommittee on Health, Employment, Labor, and Pensions, Congresswoman Frederica Wilson, for a closing statement. And thank you very much, Madam Chair, for bringing us together. I yield back.
I now recognize Help Ranking Member Wahlberg for his closing statement.
Thank you, Madam Chairwoman, for this hearing, and thank you to the panel for being here. And I agree, Madam Chairwoman, that this indicates and shows that this is not a partisan issue. This is a bipartisan issue of concern. Now, we may not agree on every point. I think you understand that. I think a lot of what we teach out there is caught, not taught, by verbs and nouns, pronouns, statements. And so I can never support the fact that abortion is a good choice for a woman or a child, or society, because it, again, reduces the value of the human life itself. And I understand there's a disagreement on that. I have a concern about any type of support for intimate partnership, that term, as a man that says to me, I don't have to make a commitment that's lasting. I didn't educate my sons that way. And I'm so thankful my son-in-law was not educated that way either. And we can disagree on that. But there's a lot of things we can agree on and move forward. Certainly, I was glad to support funding and continue to support funding for federally qualified community health centers. I have a number in my 7-county district that do excellent work and provide services that families, individuals wouldn't get otherwise. I can see supporting extension of Medicaid for mothers and children after birth to a legitimate, realistic, and important period of time to make sure that we deal with those issues of concern. I certainly can see that. So I guess I would end, Madam Chairwoman, and all those who are interested here today, that there are some things we can agree on to make a pact for. I wrote a few things down. There could be more. But let's make a pact to love all babies beginning at conception. Let's make a pact to love and support mothers and motherhood. I hope you see the difference. It's special. Let's make a pact to push fathers to do all and anything they can to protect and care for their children and the mother of their children. Let's make a pact to do that. Let's make a pact to motivate all agencies and policymakers to implement science and research-based life-saving procedures and policies promoting birth and maternal health. And let's make a pact to promote the family structure that fosters positive maternal and infant health and functional families. And let's make a pact to say, you can't have everything without sacrifice. So make sure that we promote an understanding of the sacrifice that it takes in each individual situation and person to ultimately come to the end result of promoting quality maternal and infant health and the continuation through their whole lifetime. Thank you, and with that, I yield back.
Thank you, Mr. Wahlberg. I now recognize myself for a closing statement. I want to add my appreciation to the wonderful witnesses for taking the time to be with us today. You were phenomenal. We have many, many hearings, many, every day, and you are a panel that I would rate A+. Thank you so much. The United States is home to some of the best medical care in the world. People come here from across the globe seeking medical treatment they cannot otherwise access. Yet, each year, tens of thousands of mothers across the country, particularly Black and brown mothers, cannot access the quality care they need to have healthy pregnancies. As our witnesses made clear, these mothers face barriers to securing proven government services and quality health care. They face severe gaps in coverage that restrict access to care, and they face systemic discrimination and racism throughout our health care system. For too long, the federal government has done too little to address these complex issues. As a result, our nation's maternal and infant health is falling behind the rest of the world. The time to act is now. This Congress, we have a bipartisan opportunity to fight the maternal and infant health crisis together. We can and must pass legislation that follows research and evidence, supports proven federal services, and expands access to quality health care for all mothers. Moving ahead, I look forward to working with my colleagues on both sides of the aisles, and I am just happy to hear what they said today, to advance proposals that achieve those shared goals. If we work together, we can succeed in delivering for the mothers, the infants, the communities, and the future of our country. If there is no further business, without objection, this committee stands adjourned.